That's fine.
And
I know.
do they have an on-off switch, just in case?
You do, I don't think any of us.
It's the only one that does.
Yours is, yeah.
Awesome. All right,
Strategic.
let's go ahead. Are we ready to call the meeting to order? Okay, I'm going to call the meeting to order. Welcome to the April 18th, 2017 Multidisciplinary Advisory Committee meeting in beautiful Oakland, California. I'd like to do the roll call and establish the quorum.
Okay. Dr. Klingborg,
Here.
Dr. Druces,
Present.
Dr. Grant,
Present.
Dr. Pollard,
Here.
Dave Johnson,
Present.
Christy Pulowski.
Here.
Thank you. Diana Woodward-Hagel, Jennifer Laredo. Here. And Dr. Sullivan.
Here.
Let the record reflect that we have a quorum.
Members of the audience, it is optional, but at this point would be the time if you would like to make yourselves known to the committee. Please introduce yourself and your affiliation.
Leah Schufeld, CDMA RBT Committee.
Ken Pulowski, CVMA.
Valerie Fenstermaker, CDMA.
Cindy Savory, Sacramento Valley Veterinary Technician Association and CVMA.
Nancy Ehrlich, California RBT Association.
Erica Hughes, State Humane Association of California.
Bonnie Lou.
Oh, good.
Show Waterhouse Veterinary Medical Board.
Joe Buck, Public Consumer Affairs.
All right, great. Thank you, everybody. Moving to the first item in our agenda, review and approval of the January 17th, 2017 meeting minutes. Any discussion? Yes? Yep.
I just have one
Jennifer?
correction. On page 8 at the top, Dave Johnson got a promotion to doctor.
He does that a lot.
You know what?
We appreciate that.
Yes, we do.
Thank you.
He's been studying hard, I understand.
Correspondence.
Page 2, under number 4, 1, 2, 3, fourth paragraph, last line of that paragraph, I think the word necessary should be stricken.
One more time, the location, please, Jeff.
Page 2,
Yes?
paragraph 4, item 4 rather, paragraph 4,
Okay.
last line on that paragraph has the word necessary, which I think is unnecessary.
Yes.
Necessary is not necessary.
That's what I just said.
I think that they meant necessarily.
Yes.
Yeah, yeah. But fair enough. Yeah. It doesn't change the meaning to strike that. Other additions, subtractions?
Move approval.
Second.
Any discussion? Discussion from the audience? All in favor of approving the minutes as altered, say aye.
Aye.
Opposed? Okay. Motion carries.
If we could, Mr. Chair, if we could just let the record reflect all members present voted aye, because we're sort of in.
Ah, yes. Would you like us to do a roll?
No, that's okay. All members present will record voted as an aye, and then going forward, if we could just have a roll call, that would be
That
be compliant.
So all members present did vote aye, and henceforth we will do it one by one. Item number 4, sorry, update from the Complaint Process Audit Subcommittee. Drs. Pollard and Grant.
We,
Microphone's close to you there, Bill.
it's not in there. Okay, we'll give a verbal report because we have just met reviewing cases on the 6th. Drs. Pollard and I met in Sacramento and went through a number of cases. We will have a report at the fall, a written report at our upcoming meeting for that. And then because of that interaction, we did also meet with the expert witness training group yesterday in Sacramento and reviewed a lot of our findings with them. A big part of what we said in the past is it's one thing for Dr. Pollard and I to review these things, and then it's another thing to get that information out to the people that it really affects, which are the expert witnesses, to try to make the expert witness program go. I thought it was a great expert witness training session yesterday. It was an all-day event and well attended.
I'd just add that there were 4 or 5 new experts yesterday, so this would have been their first roundtable training. Very valuable for obvious reasons. And several of the presenters, in fact, all of the presenters, were other experienced experts. So I think continuing ongoing training is certainly necessary and obviously happening, and I think they're doing a great job. The board staff put on a very well-organized session with slides and speeches and question and answers, and I think it was very productive.
Any questions from the committee for the subcommittee, complaint audit subcommittee? Any questions from the audience? If you can come forward and use the microphone, please. There's our answer. There's our answer.
Bonnie Boots. My question just relates to the fact that during this training, are they being trained as to how the board wants them to interpret the regulations? Because I'm finding some difficulty there, especially with the interpretation of the regulations, that the experts are sort of winging it when it comes to that.
Really, the training yesterday was, as Dr. Pollard said, it's an orientation for some of the new members. There was, with regard to regulation, there was reference to what section to look for with this type of a problem with the practice of veterinary medicine, but there was no specific interpretation at all discussed. I mean, it's not, if you see this, you need to go this way and interpret it this way. So it really was information, and as Dr. Pollard pointed out, prior experts that were also in attendance that gave examples of what they did and how they went through a court case and testified and things like that, but there was no discussion of an interpretation of a specific subsection or part of the Practice Act.
I would just request that that might be something you would consider, because what I find is that the enforcement analysts, I deal with the enforcement analyst interpretation of the regulation, and then I oftentimes deal with a completely different interpretation by the expert. So that's a problem for me, especially when I have to try a case. So just a suggestion.
Yeah, well, I think, I don't know if Candace wants to address it or say anything. Dr. Pollard and I were there just as resources because we have reviewed these closed cases, but this was put on by board staff and Candace. Betsy's not here, so Candace could probably address that directly.
Yes, please.
Thank you.
Like the doctor said, basically what we're providing with that training is a list of examples and kind of information, thank you, with regard to what some of the experts have seen and how they've written their reports. I wasn't aware that there's a disconnect there, so maybe if we could talk more about that later and get some specifics, I can address it.
Is that microphone projecting okay, the audience microphone? Because I'm hearing me.
It's quite low in relation to the others. We're going to have to get that one raised to a little higher level.
Okay. Any other questions from the audience regarding the complaint audit subcommittee's work? All right, we will move forward with item number 5, discussion and consideration of extended duty for registered veterinary technician regulations.
So The MDC was presented with a list of 7 different services that the California Registered Veterinary Technician Association asked specifically the board and then the MDC to look at these particular procedures to determine whether or not they should be deemed RVT-specific tasks. And in trying to gather more information about necessity, access, risk, and all of those areas that would in fact speak to whether or not this is a public demand consumer protection process we need to go through to determine whether or not it's appropriate. And we sent a letter to CARVDA on February 8th. It's in your packet, and it asks some very specific questions about whether or not these tasks involve surgery, whether or not there is inherent risks with these tasks. Does it necessitate extending or restricting, current job tasks? And if so, why? Why are we doing this? And what's their kind of rationale for bringing this before the MDC? So several weeks ago, we received a letter, actually on March 29th, from CARVDA, where they responded to some of those questions, and that's also in your packet. So I think it might be helpful to kind of go through each of the tasks just in terms of explaining what the request was, and then open this up for discussion to the MDC and the public.
Yes, Dr. Druces.
So right from the beginning, I would have a question about the relative application of these 7 procedures. Are we to interpret them strictly from a small animal practice basis, or are they to have general application to all species in all practice types? Specifically, I would look at nasogastric tube intubation, and what's termed here as advanced nerve block techniques. I would interpret that as diagnostic nerve blocks in equine practice. And so from the upstart, I think we need clarification there.
Other comments from the committee? Yes. Good. David.
Actually, there are more questions than comments. The 2 areas that I have concern about are these procedures being taught in the RVT training programs, so that when the RVTs are coming out and getting ready for their exam, they've had exposure to all of these. I have not taught for several years now, but I know some of those are taught, but I don't know that all of them are taught in the RVT training programs. So I'd like to hear on that issue. And then I've never looked at the national exam, so I don't have knowledge there, but are they being tested on these topics also, so that we have some criteria by which to judge their knowledge of this topic? Granted that the veterinarian has the final say in whether someone can perform this task, but the state of California has the responsibility for the testing and issuing the registration, that they do have the necessary entry-level knowledge of those areas. So those would be 2 areas that I would have some questions in.
Dr. Pollard?
I'd like to ask if we're going to decide on the whole group as a unit, or if we're going to discuss each individually, because I see a significant difference in risk and technique and potential bad outcome in several of these, not so much in others.
The 7 questions that were asked of CARVDA, and thank you for the response and the information, the background, it was very helpful. Those originated from a document that is from the Board of Nursing, and they recognize standardized procedures and whether or not something needs a specific protocol. So that these came from already an existing document to a significant degree in the Board of Nursing that has served them well. That's so, just so that you know the background there. And the committee has in front of it an informal document that I put together that has listed these different procedures, and then across the top has whether there's surgery involved, suturing, is there an access or a need issue, harm, what's happening in other states in the RVT curriculum, just as a way of trying to sort this out a little bit. We're kind of in an interesting position here in this coming forward because the Practice Act does not speak specifically to these procedures. Does that mean they're DVM only? Are they DVM and RVT only? Can anybody do them under the direction and supervision of a DVM? I mean, that's, I think, the interpretation. And so now we need to have this conversation to some degree about whether some of these procedures are at a higher level and should we start to create restrictions of tasks. So that's in front of us, and the hope is that in looking at this graphic and Carta's answers, that can help us at least move some of these and say, okay, these are probably not high priority for us to discuss, and then we can focus on the few that are of higher priority. Jennifer.
When this list was first presented as exclusions for veterinary assistants, I was concerned that even some of these are so invasive that even RVTs should not be performing these. And in the last line of Carta's letter, they recommend that these tasks be restricted to RVTs under direct supervision, and that put my mind at ease a little bit in that regard.
Yes.
Well, under that, they actually confused me a bit because they start off their letter, and I was going to just mention that. They start off under question 3 by saying, restricting these tasks to RVTs and veterinarians should increase in consumer access to these tasks, assuming that RVTs will be able to perform them under indirect supervision. So I was a little bit concerned on what their request was, because they mentioned some, they mentioned both. That's on, that's question 3, when they answer question 3.
It's page 4.
Page 4. So I'm a little confused what their request is. It's at the top. So that was my biggest question.
So this committee, again, has been tasked with taking a look at this, but we've turned around and asked Carta to explain to a certain degree and justify why should we be taking a look at this. And there were questions of access. Is there an access issue? Is there a harm issue? Again, is this being taught in RVT school? Because the committee should not have to spend significant resources and time when we only meet a few times a year discussing any idea that anybody has. They need to come in front of this group with kind of a packet and an idea, a justification for why we should be addressing some of this. Now, we've heard lots of testimony that RVT tasks haven't changed substantially over the last couple of decades with a couple of exceptions. And so maybe it's just time for us to catch up on some of that here. But yes, there's a lot there that we have to grapple with. And so why don't we decide what we want to discuss in terms of, do we want to bracket it in terms of RVT only, or do we want to talk about supervision levels? How do you want to approach it? This is our baby at this point.
John?
Oh, yes.
I also don't want to be, I appreciate this list because I don't want to look at the list of states and say, oh, look at all these states that allow all these tasks. Let's not be fooled by this list, because if you look at this list only looks at maybe 1.5 of the tasks that are presented to us. And that's task number 6, and it partially lists task number 2. It does not list every other task that's in here. So we need to be sure that, and I did look through some of the practice acts through some of the different states, and so it does not, this only addresses a few of the tasks that were presented to us, not all of the tasks. So to be clear on this list of states that they gave us on the level of supervision required.
So ideas on how to move forward?
I would say that, we can go through and discuss these individually. I do think Dr. Drucey's comment about large animal, small animal is also very pertinent. I think that we can certainly discuss access. I'm not sure, I don't see an access issue existing at this point. As far as the consumer, which is what I'm certainly keeping in mind, some of these procedures just don't belong in the hands of anybody but a trained veterinarian. And that is looking at the potential harm. There's, in their complications they list, there's never a mention of death in any of these, and death is definitely a complication of some of these issues. And if that's the problem, if that's the issue, then putting this in anybody's hands other than a licensed veterinarian, I don't feel comfortable with. So I have no problem going through these individually, or I don't know, have discussion with veterinarians about what that potential harm may be, however you want to do this.
Yes.
I just wanted to bring up one additional point to follow up on what you had commented on, Doctor. Looking at this list, one of the things to keep in mind is as we sit here today, every one of these tasks can be performed by an RVT or a veterinary assistant as long as the veterinarian has assumed the responsibility of determining the competency of the person performing the task and also provides the appropriate degree of supervision commensurate with the type of task being performed. So these already can be done. So that's one of the issues that we're looking at is, okay, these can already be done. So the issue is then the consumer protection of should they be delegated to RVTs and veterinarians only. Now, I think it's foolish for a veterinarian to assign some of these tasks to a veterinary assistant. I just think that would be very inappropriate, but for all I know, there's a special trained veterinary assistant out there that some veterinarian feels very comfortable having these tasks performed. And so that creates this real dilemma here, because I know the veterinarians are expressing a concern that these are very difficult tasks. They should only be performed by a veterinarian. But I'm having flashbacks to the original job tasks where we heard those same arguments about anesthetic induction and suturing and all the other things that have been written into the Practice Act for RVTs or veterinarians. And so I think it's time to look at these, but also keep in mind that there's nothing today preventing any of these from being accomplished in a veterinary hospital.
So I disagree. I think that by my understanding of 4 of these tasks, they do involve some component of surgery. The central line placement, tracheal tube placement, chest tube placement, and intraosseous catheter. I realize with central line that there is the relief hole provision.
Right.
So perhaps that one is different. We've already separated that out. But the other 3, generally speaking, while there may be surgery-free chest tubes, in most cases, there's still a skin incision involved. And I don't think that RVTs have a blank check to do skin incisions anywhere and everywhere. It's, we've got the oral surgery component for RVTs in terms of suturing, and then we've got the relief hole component for RVTs as far as actual surgery. So it seems to me that tracheal tube placement, chest tube, and intraosseous catheter, because they're already involving surgery, probably exclude anyone but DVMs just by the nature of the procedure.
True, but it could also, the veterinarian could just do their component of it and walk away. They could make the initial incision and someone else could follow up after that. So, I mean, there are ways to deal with that issue.
Yes.
I would also take exception with that. I do think that some of these, like make an skin incision for a chest tube, placing a chest tube, in my mind, is a surgical procedure. It's invading a body cavity. And I do think the Practice Act addresses a number of these in general terms without specifying which one of these on this list they can and they can't do. But the next question is where does it stop? I mean, is an unregistered assistant able to do a skin scraping? Are they able to look at a slide under a microscope to do this? I mean, do we really need to delineate all of the specific tasks that are done in a veterinary hospital and say, you can do this, you can't do this, or you can do this? And then are we looking at, passing these tasks and diverting the responsibility from a DVM to an RVT? And I'm not sure what that really accomplishes. If you're talking about limiting somebody else, I think we as veterinarians understand what the limitations are, and I would go around this table and ask any veterinarian here if they would be having veterinary assistants do this. And my bet is you're probably going to get a unanimous no all the way around, which is exactly what the system is. Do I think this system is broken? Not at all. So I'm not sure what we're trying to fix and what we're trying to attempt to be done. What's the point of doing this?
Dr. Druces?
I agree, and I would throw this back at staff's table and question, in the big picture of things, do we really want to have policies and procedures that are so prescriptive in nature that every task, be it old or new, has to be evaluated and placed in a category that defines who, when, where, and what it can be performed? I think that is overly burdensome. And since the veterinarian has the ultimate responsibility for all of these things, irrespective of where it may be placed in some list, I don't see the real need to discuss much about this, frankly.
Yes, Jennifer.
Just to respond to Dr. Grant's comment about all of the veterinarians here not agreeing to let somebody else perform these tasks, all of the veterinarians sitting up here are a little more ethical than the average bear. There are plenty of veterinarians who have no problem letting veterinary assistants do these tasks for whatever reason, but it was my understanding that this list was presented to the board. We were made aware that this was potentially an issue, and I think we have an obligation to explore that. This is a consumer protection regulatory body, and we do need to address this.
And I think we're trying to find the best pathway to do that. So is that by looking at whether it involves surgery or suturing? Is that by trying to assess a harm scale? At what point does it meet this level? And, okay, these are things we need to discuss, these are things we don't need to discuss. So we're trying to find a sorting mechanism here. Yes, David.
Just one other question for Anne Marie. On the enforcement side, how frequently are we seeing complaints filed against veterinarians for letting staff do things they're not qualified to do, whether it be an assistant or an RVT?
So I did talk to our in-house consultants who see the cases as they come in and assess, whether or not there was a departure of standard of care, unlicensed activity, or some other violation. And because the majority of the complaints that come in are consumer complaints, they don't necessarily know who was treating their animal. They know it was someone other than the veterinarian. So it could have been the RVT, it could have been a veterinary assistant, but the complaints that come in are, the veterinarian never saw my animal. The only time we see complaints that are specific about these more invasive procedures is an unlicensed activity complaint, where there is allegations that an unlicensed individual did a spay or neuter. And we have seen those complaints in the past. But in terms of the specificity, a consumer's not going to know. And granted, these things are happening in the back office. They're happening in an exam room or a surgical suite, and the consumer's not going to be aware of who's doing what. And they don't really understand the difference between all of the individuals that work at the veterinary practice to begin with. So it's really difficult to extract from a consumer complaint that we have an issue with veterinary assistants doing something that RVTs should be doing or vice versa. What we have is a consumer who understands that it's someone other than the doctor who is performing what they would consider maybe a more complex or high-risk procedure, and they're complaining that it was someone other than the licensed doctor who provided that service. So it's very limited in terms of the information we can garner from a complaint.
Yes, Jennifer.
Just to add to what Anne Marie just said, having worked in a 24-hour specialty, I will say that consumers come in and they might talk to 10 different people. We're all wearing scrubs. We all have a stethoscope. They don't know who's who, and they don't know what we do once their animal is in the back.
Right.
So the statistics would not be accurate as far as the complaints.
So I'd like to hear from members of the audience for a few minutes, and that will hopefully help us then figure out how we're going to sort through this. Because because I'm an optimist. Would anybody like to?
Nancy Earlis with Barsha. First, I just would like to remind you that it was the Veterinary Medical Board that asked us to provide you with a list of potential extended functions. It wasn't, the initiative didn't come from us, it came from the board. So our subcommittee came up with this list, which may or may not be considered extended functions. As David pointed out, these tasks are already tasks that RVTs and veterinary assistants can do, and our subcommittee felt that these were tasks that should be limited to at least to an RVT because of the skills required. My concern about this adventure is that while this list is very interesting, there are, next year there will be other tasks that they didn't think of, and it might be more sensible to come up with some sort of a statement about tasks requiring the skills and knowledge of an RVT rather than a specific task, because otherwise you're going to be having to revisit this list every year. So you might want to think in that way about changing the regulation that veterinarian may assign a task to a veterinary assistant or an RVT, but those tasks requiring the skills of an RVT should only be delegated to an RVT. So that's something I would suggest.
Other comments? And for fun, let's have somebody try this microphone because that one's not coming through. Yes.
I guess I shouldn't come to these meetings because I'll always have a comment. Can I just talk loud?
We really, yeah, they won't come through on the video.
Okay, I just have two comments. As somebody who deals with this on a daily basis, I have one comment is, to me, it's a standard of care issue. It really shouldn't be that specifically listed in the regulation because you will have to revisit it constantly, and it gives permission to the people who aren't doing very good medicine to allow people to potentially do things that they shouldn't be doing. But then at the end of the day, it's a standard of care issue, which goes back to the doctor. But as somebody whose life is interpreting these in the lights of complaints, I would really have a problem if there were specific tasks listed really specifically that then 2 years later, the standard of care had changed.
And just a point of clarification, the extended functions conversation that we had actually was specific to shelters. And we had a subcommittee that was looking at that. And Carta, we appreciate the input because RVT tasks have not been looked at in a long time, as we mentioned earlier. But that wasn't actually the agenda item, was to go in this direction. It was specifically regarding shelter medicine at the time, which is still in play. I mean, we're still working through that. Any other comments from the audience? So one of the things that I did was go through Clinician's Brief, which is a peer-reviewed journal, and tried to look at harm scales on these various tasks. And I think that would be an option for us if we wanted to look at this in that way. We could also try and move this into a subcommittee and have them try and work through some of this and then come back to us. We can talk about every one of these tasks at this point individually. It's really, yes, please come forward.
Yeah, I agree.
Hi, I'm Dr. Aldretti, and just as a sideline on some of these nasogastric tubing, especially in equine, at the latest AEP meeting, there was a paper written about more frequent tubing of horses and giving them oral fluids to combat colics, and there's been quite a remarkable, actually, there was statistically difference in the improvement of colics for more frequent nasogastric tubing, most of them being done in a surgical facility because of the fact that it's really difficult for veterinarians who are doing ambulatory work to go and tube horses more frequently on a daily basis, like every 2 or 3 hours. But nasogastric tubing in horses has quite a large potential for damage if it's not done properly. So a question that was asked earlier was, are we teaching these in RBT classes? And the answer to no, not at this point, because it's not a task that has been approved to be done by technicians. So if this was going to be done, I think there would have to be a period of time where these things would have to be allowed to be taught in class, or at least the potentials for the dangers of it to be taught in class. And then a proficiency, part of the proficiency list that would have to be signed up veterinarians would have to be done, that these people are competent to do these tasks before they would be put into place. Same thing with digital nerve blocks. In horses, it's a very common procedure that we do. But again, it's a diagnostic technique as well. Potential for not doing it right, and it's there. You can get erroneous readings even when you're done by people who would know how to do them because of the migration of local anesthetics in the facial sheets. So all of this stuff I think has to be taken into account before we look at what are we going to be doing with some of these tasks. I think there is a place for RVTs to do these, but I think we need to have time to be able to either adjust the way we teach it and how we teach these things before the procedures are done. I know that RNs put nasogastric tubes in people in hospitals, but they've had training in that area as well.
So Dr. Aldretti, the Practice Act is silent on these tasks. It doesn't talk about nerve blocks. It doesn't talk about nasogastric tubes.
No, but it's actually when we wrote the Practice Act way back when, it was originally advised by legal counsel was that these tasks should be broad so that we're not pinned into a very narrow interpretation of the law, and allows the Veterinary Medical Board then to have more discretion as to how we're going to interpret these. And so it's a responsibility of the board then to come back and say, this comes within the realm of this task, okay? And we can make exceptions to this task upon qualifications of certain issues, and weighing the dangers to consumers as well as dangers to the public, to the public or to the animal. Okay.
Thank you. Christy, and then Dr. Grant.
Okay, hope everybody likes me and Dr. Grant's glasses today.
Thank you.
So, 2035 takes care of this, because it says very clearly that supervising veterinarian shall be responsible for determining the competency of the RVT, permit holder or veterinary assistant, to perform allowable animal health care tasks. Why? That's what we're talking about. We're letting the veterinarian determine what they can do, what they're competent in doing. That's why we don't need to list out specific things, because the veterinarian needs to be the one that's, responsible for knowing what their staff is capable of doing. I don't.
Dr. Grant, and then Anne Marie.
I would agree with that general statement, and Nancy's point, I do think it needs to be kept generally, and maybe a comment from legal that if we start listing a bunch of these tasks and somebody then starts to say, well, they didn't list these 2 or 3, maybe that means they thought about them, but they're okay to be done. And so you get sort of the opposite effect, well, how come they didn't mention this? And And going through these and looking at every task is, I think 2035 pretty much does it. And then the only other thing would be if we're going to do that, you know, I'm all in favor of getting a subcommittee together, have them look at 2035, have them look at these tasks and see what needs to be made as far as a general statement.
At the last meeting, we talked a little bit about what you just touched on, which is do we have a scope of practice issue or do we have a delegation issue?
Right.
And, you know, I would argue based on the comments, we had perhaps there's a delegation issue, although it's very hard to find evidence of that unless you have some sort of complaint data to support that. I do want to just kind of correct the record. CARVTA did bring this issue before the board. It's been before the board for several years, which is we need the board to look at extended duties for registered veterinary technicians. I think the reason we ended up with a list is because we didn't know what those extended duties were. And when we pressed for more information, it was really restriction on some duties, extension on others. And that's why we're seeing kind of this blend of some duties need to be restricted, some duties perhaps need to be extended, if that's even an appropriate description of what would be occurring. Just for a point of reference, and if we do end up moving in the direction of a subcommittee, there is an occupational analysis that was recently done for the registered veterinary technician profession, and it is on the board's website, and it's as current as December of 2016. So I would invite those to look at, you know, some of the task lists, knowledge lists, the skills appendix, because it may be very helpful in terms of general statements about what is expected of an RVT when they graduate and when they come to get a license from the board in California. There will be a linkage study to the occupational analysis with the actual veterinary technician national examination, and that's ongoing at this point. But I think that really does serve as the basis for what are the knowledge, tasks, and abilities, what's expected of an RVT in entry-level practice. Now, that doesn't mean that at some point in time you shouldn't necessarily consider some sort of advanced certification, if that's what we're talking about, or advanced function acknowledgement. That's different than saying every RVT that graduates from a program as entry-level practice is skilled in some of these more complex and invasive procedures. Maybe what you're talking about is an advanced function. And that happens all the time in professions. But that requires a study of, you know, again, necessity, where they would get the training. Would it just be OJT? Would it be something that they would be trained for in one of the programs? I think it's a very healthy discussion, but again, it comes from somewhere. There's got to be a driving force for this that either comes from a need, a risk, a potential risk that we're not addressing, or some sort of complexity in how the profession has evolved, and we have not kept pace. So I agree with many of the comments that were made today, specifically when we're talking about a standard of care. If you start trying to define every aspect of standard of care, I guarantee you're going to find yourself in a black hole. It's just not legally defensible to do that. But if you do start to see this evolution of practice where we need some higher level skilled practitioners at the RVT level that can do advanced functions, then maybe that's what you're talking about. But it's really important to frame this discussion, that we know what direction we're going, so that we don't spread our resources so thin that we start looking under every rock when that's not necessarily the right place to be. I hope that makes sense.
David, Jennifer, and then Nancy.
I just had one additional comment. Since we've already referenced 2035, I'd like to reference 2036, because that might be a way to look at this standard of care issue. And they're talking about RVTs shall not perform any function that represents the practice of veterinary medicine or requires the knowledge, skills, and training of a licensed veterinarian. You could take that exact statement and drop in the word veterinary assistant and put it over under duties of supervising veterinarian, in that you should not be assigning any task to a veterinary assistant that requires the knowledge, skill, and training of a registered veterinary technician. And that might be one way to address the standard of care. And I know that's a broad statement that legal counsel may not be too happy with, but it's a better statement or something similar to it than what we have in there now. And so it does establish at least a criteria that is defensible because you have the occupational analysis of what an RVT has to know and what an RVT performs as a task. And so you'd have that point of reference if someone, as you said, are unethical veterinarians out there that are creating problems for the consumers, you would have a point of reference or at least a starting point.
Thank you for volunteering for that subcommittee, David. Yes.
Do I get to keep my doctor promotion?
Jennifer.
I was thinking along the same lines as Dave, of creating some sort of a general statement under the 2036 or the veterinary assistants, restricting basically unlicensed activity of these advanced, more risky procedures, because even though we're not receiving complaints, the board should be proactive in preventing these risky things. So I don't think we can do that today, so I'm thinking a subcommittee is the best way to go.
Nancy?
I think David articulated perfectly the suggestion that I had made earlier, but I forgot to mention that our board, discussing animal physical rehabilitation, came up with the idea that perhaps there is an extended function that you need to look at, which is casting and splinting for RVTs under indirect supervision. Currently, RVTs are allowed to do those procedures under direct supervision. But we've come to learn that there's a lot of this activity going on by physical therapists. Physical therapists are applying splints to animal patients, which is a direct violation of the Veterinary Practice Act. They're not allowed to put on splints, period. But an RVT right now cannot put on a splint under indirect supervision. So we would recommend that you, especially if you have a subcommittee, that you look at adding casting and splinting under indirect supervision for RVTs to solve that problem.
Okay, great. Any other comments from the committee? Yes.
I just wanted to clarify, Dr. Johnson. So your suggestion was perhaps adding VAs to the list of things that the veterinarian could not assign under.
No,
so
it would be their duty. It would be under the duties. They have to already determine the competency of the person to assign a task, but then it would be they shouldn't be able to assign a task that requires the knowledge, skill, ability of a registered veterinary technician.
So I just want to point out that 2036.5 speaks to VAs in particular, and it tells, it's instructive in that VAs cannot perform any of the tasks listed under 2036 that RVTs can.
Right, those are the exclusive tasks, but I'm talking in general. So in other words, this list would come into play.
Okay.
Because we already have had veterinarians say, wow, I would only want a veterinarian to do that, but you might find some veterinarians that would show up, testify and say, I have RVTs that can perform these things, but I most certainly wouldn't want a veterinary assistant to perform them.
So you're saying, conceptually speaking, if the committee continues to discuss some kind of list, then perhaps VAs need to be part of that discussion, or I'm just trying to figure out where we are in the thread.
I think Dr. Grant and everyone else has said it correctly. One of the reasons we stopped listing tasks years ago was you can't list them all, but you need to have general statements that provide guidance and a position to fall back on for protection. And so we need some type of a statement regarding assigning of tasks.
So it seems to me, just reading it, and again, we don't need to do the actual wordsmithing today, but under 2035 or 2036.5B, where we start talking about subject to the other preceding subdivisions, the degree of supervision by a licensed veterinarian over a permit holder veterinary assistant shall be higher or equal to the degree of supervision required when an RVT performs the same task, and shall be consistent with the standards of good veterinary medical practices, which really does speak to you should be delegating unless it's good veterinary medical practices. You could simply add a sentence there that says a supervisor shall not delegate tasks to a veterinary assistant that require the training and skills of a registered veterinary technician. So you could expand B to clarify that if this task requires some very formalized education to be able to do it competently and with safety to the patient, that it needs the training and skills of an RVT. And I think there you're isolating certain tasks that may not be a laundry list, but may be more, this is a licensed individual that's gone through formal education and training. I mean, in terms of application, you know, you're going to then rely on your experts to say, is an RVT the one that should have done this, period? Should it have been a veterinarian? So that goes back to, that's established standard of care, and then you're relying on your experts if you get a case where an RVT does one of these tasks that we were talking about today, and there's harm to the patient. It would really go back to the veterinarian at that point. Should that task have been delegated even to an RVT? So what you're doing is you're just making a professional statement about what good veterinary practices are. Or should be.
So I'd like to have potentially a motion in a second regarding forming a subcommittee to look at language in terms of delegation of responsibilities to veterinary assistants, but also a subset of that would be to look at whether or not to change the provision for casting and splinting for RVTs and the level of supervision for that, whether or not indirect would be appropriate. So there'd be two components to that. Yes.
Yeah.
And my question would be, would this be just relative to the 7, now 8 tasks, or would this circle back and potentially include the discussion about extended duties for RVTs in a shelter situation, as was originally the intent of the board, as I understand it?
So I don't want to tell the subcommittee what their job is at this point, but.
Well, which subcommittee? We don't have one yet.
Well, we don't. But the shelter conversation is a separate one to a degree. I think that you're going to hear some people that feel that the standards for an RVT, whether it's in private practice, should be exactly the same as the shelter, and others that would argue the opposite. But at this point, this is not discussing the shelter setting, this particular subcommittee motion. It's really directed, it's been driven by the conversation of these tasks, and yet we're not delineating these tasks either. This is more, again, about levels of supervision and the appropriateness of assigning tasks to various individuals within the practice.
I'd like to make a motion to form a subcommittee to review the extended functions of RVTs in private practice and to evaluate the alteration of a extended duty for an RVT with regard to application of cast under indirect supervision.
I'll second that.
Okay, for discussion.
No offense, but how can you discuss the cast and splint thing when we don't really know where that's going? I just have a question on that. Well, when it's with the animal rehab thing.
Well, I honestly don't think that it's,
Okay.
yeah.
I'm just
yeah.
curious.
I think that's important background information on what's happening in.
For a later agenda
But,
item.
yeah.
Talk about the scope.
So, we have a motion and a second. Other discussion from the hooligans up here? Yes, I see that President Pulowski is here, but I wanted to make sure we were good. President Pulowski.
If you want to make a task force, that's fine. Mine wasn't specific to the task force. It was kind of before that, and I thought Ms. Delmanayo she started to address, but I felt pointing out that, yeah, I think 2036.5 in my, I think that addresses the veterinarian's ability and obligation to delegate tasks as appropriate. Ms. Delmonico's comment about possibly adding something, a statement as far as, you know, if something should be at the level of an RVT, actually sounds rather broad and open to interpretation. And we would, and I would have great concern that that is open. An individual can say, well, that should be an RVT task, and another individual may say not. And would just, you know, and then we start getting down to, okay, now do we need a list to say what those things are? We're right back. It becomes circular, that we need to define what those things are that are RVT only, or extended, or restricted, or not, so.
Other comments from the audience? Yes. Yep.
Personal preference, I would like to amend the very eloquently stated motion by Dr. Grant to alter 2036.5 to be more inclusive of advanced, invasive, risky tasks. I'm more concerned about restricting these tasks from veterinary assistants than including it in RVT-only tasks, just as a consumer protection issue.
Yes, Dr. Sullivan.
Anne-Marie did allude to this, or did state it, I should say. I think the subcommittee should also be looking at if we're having these types of tasks listed, I think that it's appropriate to have RVTs have advanced training and certification, if you want to call it that, in order to do these more complicated tasks. I don't like the idea of somebody, just because they're an RVT, day one, doing some of these very complicated cases. So I think the subcommittee should look at that also.
Mr.
Yes.
Chairman, it's remarkable that I have remained silent this long.
Yeah.
So just part of, from the part, we have a potential motion for the amendment, and we have a second one. I would respectfully suggest that perhaps what we may consider is we task the subcommittee, or whatever instrumentality we have, with examining all the various regulations that could potentially impinge on this function, because ultimately my presumption is the output of the subcommittee to MDC and ultimately to the board will be sort of a amendment perhaps of the existing regulatory structure. And so I would not, I think you eloquently put it, not tell the task force what to do specifically as subcommittee. I would just suggest that a broader motion perhaps be entertained, that they examine all applicable and relevant regulations, and perhaps even a little smattering of statute if that's necessary, and then report back about sort of what would need to change in order to encompass the extended functions in the various settings. Two things I do want to say that I've already said. Two things. Number one, as an instrumentality of the board, MDC and any instrumentality of the MDC is guided by consumer protection as its paramount goal whenever it exercises its regulatory function. So there's that. And then like I said, going forward, the composition of the subcommittee as far as numerically may dictate whether it's publicly noticed or not. So with that, I've said enough. Is this thing on?
Yes.
Yeah, I would agree. Just maybe as a friendly amendment, accepting something to review, including reviewing existing regulations with regard to RVT practice.
And so I think that, in that way, would also encompass the splinting question.
All of it.
Yeah.
And also the perhaps inherently risky procedures as well.
So Bill amended and rephrased the motion. Do you accept that as the seconder of the motion?
How could I ever contradict Dr. Grant?
Yes.
Of course, yes.
Yes,
Let
very
me
good.
help you.
Any other discussion from the committee? Discussion from the audience? We'll have a roll call vote.
Oh, sorry.
Yeah.
I was having too much fun.
We'll get back on task.
Yeah, I know, we will. Dr. Klingborg.
Aye.
Dr. Druces.
Aye.
Dr. Grant.
Aye.
All right. Dr. Pollard.
Aye.
Dr. Dave Johnson. Dave Johnson.
Aye.
Joke. Christy Pulowski.
Aye.
Jennifer Laredo.
Aye.
Dr. Sullivan.
Yes.
And Diana Woodward Hagel is not here. Okay, motion carries.
Very good.
I think we'll try one more.
Okay, so let's go through action item number 6, review of legal counsel's guidance on the Federal Drug Mobility Act and its impact on registered veterinary technicians transporting controlled substances for emergency treatment.
So I'm going to open just, and then turn it over to Tara. Tara Welch, new VMB counsel and counsel to the MDC, was really diligent in examining the Federal Drug Mobility Act and the Controlled Substances Act and put together, I think, a very concise statement regarding provisions that would allow for an RVT to actually transport drugs under the direction of a veterinarian in their normal course of scope of delegation. And this issue has been discussed in the past it really started when we were looking at how could we perhaps help with the rodeo situation and providing an on-site practitioner to deal with emergency services or emergency care to animals at rodeos. And we really looked at this in terms of expanding 2069, which was emergency care that could be provided by an RVT. And at the last MDC meeting, we expanded that language to include sedation and pain management under current state and federal laws. And so we really needed to know what the federal provisions would allow for, because how many of the substances that are used for sedation and pain management aren't controlled substances, and really is it reasonable to expect an RVT to be able to administer these drugs on site that aren't going to provide the necessary pain management or sedation? And typically those drugs, at least from what I heard at the last MDC meeting, are in fact controlled substances that are typically used in the field. We already know that animal control officers under the penal code are allowed to transport drugs for a very specific reason. So that is, again, another kind of layer of state provision that may expand federal law beyond the federal restrictions. The RVT provisions are a little more closely aligned in that they are under the supervision of a veterinarian who it is permissible to transport drugs, and that was a recent federal amendment, I think in 2014. So, having said that, I just wanted to set the stage so that Tara could further explain her memo.
Well, that was pretty good. I was just, yeah. I was just going to discuss why this memo was even written, and it was really just in response to a question raised in the last MDC meeting, whether or not the Federal Mobility Act had any bearing on the RVT DEA registration. So the memo pretty much speaks for itself. It just kind of walks us through the Controlled Substances Act requirements at the federal level. Then it talks about what the recent Mobility Act actually does. So the CSA requires registration if you are transporting controlled substances. That includes a veterinarian. The Mobility Act just exempts the veterinarian from additional premises registrations if they're transporting it in, say, their car or administering it at a location other than their primary business location. So then we get to the RVT, and they are, in essence, operating under the veterinarian's DEA registration because they're acting as a direct or indirect supervision of the veterinarian when they're transporting the controlled substance to another location. So that's just the genesis of where we've arrived. Just using the CSA requirements, what the Mobility Act does, and how state law operates on top of the CSA requirements.
Dr. Sullivan?
I was the one that brought that up from the standpoint that we as a profession had a very difficult time getting this bill passed, and I was surprised that that this would allow RVTs to also transport controlled drugs. Under that premise, would it not also hold that a veterinary assistant controlled substance permit holder be able to transport controlled drugs?
It seems possible because the requirement is that the RVT be registered under state law. And the whole point of the CSA is to start tracking the movement of controlled substances. So to the extent the VA has received a permit under the VA CSP, potentially, yeah, they could transport under the direction of the veterinarian.
That
Well,
bothers me.
and keeping in mind, the transport, that's really just the tracking of the drug itself. That's not necessarily administering it directly. The veterinarian still has to direct the VA under the VA CSP to actually administer. So there's at least that level of supervision.
Dr. Drusis?
I just love this interpretation and analysis. Thank you very much. I believe it solves a couple issues. One is obviously before us, and the other is the sedation / anesthesia in shelter situations under indirect supervision by the veterinarian. If we look at the last paragraph of the analysis, about in the middle, it says, when acting the normal course of business or employment, administer the controlled substance. It does not indicate to what extent the substance would be administered, whether it be for, in the esoteric discussion of sedation versus anesthesia. And I think that leaves it open, if you will, to address the issues that I've been concerned with all along, and that being animals presented in a shelter, the veterinarian is not there, but has protocols, descriptions of what needs to be done, and allows then RVTs under those situations to do, I would interpret it as anesthetize an animal for various, oftentimes non-invasive reasons, certainly not doing surgery. So I would wholeheartedly support this analysis and interpretation, and would bring it back up again when we talk about RVTs and shelter duties.
So Christy has a comment, and then Tara, I'm going to ask you to respond to his interpretation of your interpretation. Okay.
Yeah, I would prefer not to get into this because I think it goes into the anesthesia versus sedation comment, but I think that's a broad interpretation of it, because if you read induction and you read anesthesia in the Practice Act, it clearly states that the veterinarian must examine the animal before, within anesthesia, it's 12 hours, and inducing, the veterinarian is required to examine the animal. So, and it doesn't say there's no setting. So that is a very broad interpretation.
So, and my response would be to be very careful about over-interpreting this memo.
I'm all, wow, how did
Right.
we get there?
Constitution.
Well, I can appreciate what you're,
Attempting to do.
yes.
Thank you.
But, yeah, this was really just about trying to figure out how the federal laws apply to the registered RVT. And this is really primarily written from potentially a private practice scenario. So to the extent there are other statutes or regs that limit an RVT in a shelter situation, we would need to look at that situation separately.
I appreciate all this discussion. I view this as having 1 foot at least in the door right now. And if push comes to shove, I'll just have my RVTs take the animal and the drug into the parking lot and sedate it there and then bring it back into the clinic.
Because then they're an ACO.
Because then they'd be an ACO, that's right. So,
Okay, before Dr. Drusis gets himself in any more trouble, questions, comments from the audience, please come forward.
I just wanted to make a comment about what Dr. Sullivan brought up about veterinary assistants transporting controlled drugs. While this interpretation may allow them to transport the drugs, it doesn't allow them to actually administer them outside of an animal hospital setting. Veterinary assistants are only legally able to perform procedures in an animal hospital setting. So they can transport the controlled drugs from one animal hospital setting to another, but they can't administer them in between.
Yeah, it does say hospital setting.
Yep. Other questions, comments? Any additional legal interpretations? We're good? Okay, great. So thus endeth agenda item number 6. Are we good to keep going, or do you want to take a break at this point, folks? Break. Okay, let's break for 15. We'll be back at 11:30, and we will start on time. Are on agenda item number 7, discussion and consideration of recommendations from the State Humane Association of California and the California Veterinary Medical Association regarding public and private shelters and minimum standards and protocols for shelter medicine. And so where I think we left this was with Shaq and CVMA. We're working through some language, and we had kind of tossed the ball in that direction. And if we may have an update on where we're at.
She stepped out.
Oh, okay. Okay.
I know.
That would, yes.
We're all looking back there. She's
Yeah.
gone.
Yeah.
We can reorder if we need to.
Yeah. Well, we'll give it just a minute or two. Moving on. Yes.
Yeah, Bonnie's looking for her. She doesn't see her.
Okay, well then let's move to agenda item number 8. That's easy enough. And agenda item number 8 is a review and consider proposed regulations regarding the compounding of drugs pursuant to the enactment of Senate Bill 1193. Dr. Sullivan, would you like to take the lead on this?
Well, I think I'm going to turn it over to Anne Marie because we had a meeting last Friday with the Board of Pharmacy, and she took better notes than I did. So I'm going to turn it over to her, and then I will just comment on my impressions of the day.
So as Dr. Sullivan mentioned, he and I met with pharmacy last Friday. We met with the executive officer, Virginia Harold. We also met with their supervising inspector, who is their chief compounding specialist, Christine Acosta, and their assistant executive officer, Ann Sodegren, and also their enforcement chief. And really our goal was to explain to them the limited compounding provisions that we're trying to formulate for the purposes of veterinary practice. And our goal was to define veterinary compounding as something separate and apart from what a pharmacy would do, and separate and apart from what a physician would do in terms of in-office compounding. So I think we had some success in terms of explaining the limited amount of compounding that veterinarians typically do for their animal patients. There's a few sticking points, and those would be trying to define the best beyond use date, specifically for sterile injectables. The example that we've used many times is the cocktail of ketamine, Valium, and acepromazine, and how, in fact, you would possibly use that for more than one animal patient, so it's not drawn up in the syringe, inject into the animal, and then discard that cocktail. That becomes not only cost prohibitive, but also the idea of having to enter that vial over and over and over again to provide that same cocktail to a number of patients in a high volume practice really is more of a safety issue than if we were to perhaps maintain that cocktail for a certain period of time. So their concern is, how do we define what a reasonable beyond use date is for sterile compounds? And there was some concession that, we need to start somewhere, right? So we need to define our regulations. We've asked for their input. They recognize that this is our lane and we need to regulate veterinarians who are compounding drugs, and they will provide as much guidance and expertise as we request. But again, they don't want to regulate veterinary compounding. They want us to be able to start with a limited scope in terms of simple compounding, which would be the basic compounding practice that's covered in 795. Non-sterile is already defined in CCR 1735. Perhaps we need to look at being more specific on the self-assessment, quality assurance type mechanism that a veterinary premises would have in place for assuring that their practices, in terms of how they're training their staff, how they're assessing their outcomes, there's some form of quality assurance. If they have a unfortunate or unexpected outcome with a specific compound, that they would go back to their protocols and make sure that they're doing independent quality assurance of their practices in-house. Also, some sort of training protocol for their staff, for their RVTs. In that training, there was a mention of defining single-use vial versus a multiple-use vial or a multi-use vial, and defining a BUD date from the start of administration, especially for IV fluids. So there was also a discussion about what we would call hazardous drugs, and there is a new USP 800 that's coming down the pike that would really impact veterinarians from being able to compound chemotherapy drugs and hazardous drugs. The requirements under USP 800 are extremely complex, and I don't see that as being maybe a first attempt at this limited scope of regulation. However, I do see that we would be able to at least define training, quality assurance, supervision, the simple compounding that we do, and some limited sterile compounding with a very conservative beyond use date specification. And I think that's where we start.
Well, I'll give them a little more personal side of it. It was very interesting when I got in there and found out that Christine, who is the head of compounding, was there. I had flashbacks to her ripping apart our draft a couple months ago and thinking, oh crap, how's this going to go? And but Anne Marie is great to work with her working relationship with the staff at the Board of Pharmacy. A lot of small talk before it started, and everybody got kind of relaxed. And as the meeting went, it became more comfortable. We didn't show them what we've done so far. We kind of went there asking them, how can we handle some of our situations? So early on, Christine, the compounding lady, asked if we could live with USP 795, which is the non-sterile compounding. And before she got the question out of her mouth, Anne Marie said, no. Christine says, okay, we won't go there. And then the give and take of examples of non-sterile compounding and sterile compounding that we do daily. I found that then saying, well, maybe you can do it this way, or maybe you can write it this way. And one of the examples was the multi-vial bottles that we're making our IV sterile products from. And she says, well, if it's, are they multi-vial or bottles that you're getting a
multiple
from?
use, yeah.
Multi-use, and I said yes, and she said, well, they're going to have preservatives in them, so we can extend that date. She said, I don't think we can do it 28 days, but maybe 15. So it was a great conversation. It ended up with Ann, who was probably more concerned about the technical part of the paperwork and everything. Basically said, you know, you're going to need to write some regulations, live with them for 5-6 years, come back and fine-tune them. And that kind of gave me the impression that it's a green light, and we just need to refine what we've started with. I think we're on the right track, and see if we can't maybe go back to them with our changes, and you know, because they kept thinking that what we're doing is really complex. And she said, you know, you got to have training. You got to train these people how to do it safely. And I said, well, first of all, there are IVTs that are doing fairly complex procedures already, and what we're asking them to do is to take 1 milliliter out of one bottle and put it into another. And she said, well, just document that.
Yeah.
I said, okay. So, you know, they want a paper trail, and I think some of the requests that they have for a master formula and for a manual, I said, really, you know, ours are so simple, we could put them together. And she said, absolutely. So I had an example of a sodium bromide that, which was a good example. And when Christine took a look at it, and she said, 250 milliliters of water, you're not going to get more than 14 days out of that. And I said, yeah, but we do, because we've been using it long term. And John said, sure. And John was on a phone conversation with us, and he said, sure, we measure the blood levels of the bromide, and if the product is failing, they're going to have more seizures. So, you know, we do see that there's a stability and quality control. And she says, well, that's your stability study. So I got, you know, they really bent over backwards to try to help us get the documentation that I think we're going to need to have to do what we're doing.
Yes.
For injectables with Valium and things, how are you measuring quality control, or how are we supposed to measure quality control?
I think, I'm not sure, well, quality control, is it effective or not? The other, I think they're more concerned, the new wave is stability. And their concern was, what's that stability out there 14, 15 days? Maybe we may have to do some cultures once in a while to make sure that it's stable and safe. But we didn't quite go down that track. I kept saying, you know, we've been doing this for 30 to 40 years, so, you know, isn't there some justifications of trial and error? And Ann said, yes. So I think we're just going to have to document what we're doing based upon experience and any literature. Like, for example, that sodium bromide we got from Dr. Berry, who is a neurologist who taught at Davis, and we just document where we get our information from and how long we're using it, and the cases that we're using it on safely and effectively. So I got the impression that they're not looking for the type of documentation they would expect to see in a compounding pharmacy. But they are expecting to see some documentation.
Can I
Yes,
answer
Emery.
Bill's? So there is actually a definition of what quality assurance entails. And so if you look at CCR 1711, that's the pharmacy law for how they're expecting their pharmacies to conduct internal quality assurance. So there is a recipe for that in the pharmacy world. The statute that provides kind of the oversight of this quality assurance, and it's really a self-assessment. It's not the pharmacy board going in and conducting some sort of quality assurance inspection. Now, the pharmacy board does do inspection, but they don't do it for that purpose. So Business and Profession Code, Section 4125, and California Code of Regulation 1711. And I mention those sections because it would be beneficial for us as a subcommittee to look at those examples to say, is there any part of those quality assurance assessments that would be specific or at least help us define what that means in veterinary medicine? One of the problems that we discussed at length was, well, what happens if you have an adverse reaction, right? One of your patients that you've compounded a drug for ends up having some sort of reaction to that. What's your recall methods? Do you have a reporting requirement? And I was trying to explain that, you know, this is a different set of circumstances. It wouldn't necessarily be a quote-unquote recall because we're not providing that formula to multiple patients. This is a per-patient situation where that would be handled in an enforcement situation. You know, the complaint would be filed, there would have been a bad outcome. If it's not handled through an enforcement situation and you're just aware that your patient had a bad outcome with a particular compounded product, then that would be built into your quality assurance program. Was there a drug interaction? Was there a stability or a sterility issue with the drug that you injected?
There's no way that we know that, and these products that we're combining, we are off-label.
Mm-hmm.
I mean, you go to any one of these drug manufacturers, they're not giving you any information with this. It's like Dick said, though, we've done this stuff for 30 years.
Mm-hmm.
And we know it's stable. We've used bromide for 25 years, and it works. And it's both of the general things, the terms that we're talking about. And for quality assurance, are we talking one and done? Or are we talking every 6 months you do it? I mean, is there a frequency, a repetitiveness to this quality assurance?
Dick?
I was surprised when we discussed this in that she was saying quality assurance, as I understood it, is in-house
Mhm.
and it's
Right.
confidential.
Right.
They can't even subpoena that.
They can't get records from you on how you do your
Mine's going to be
quality
really
assurance.
confidential.
It's non-existent.
Nobody will find it.
Wow. And that's on webcast.
Dr. Aldretti.
Fantastic.
Who's digging the hole now, buddy?
You two
Can-
are really gonna be in a corner.
Can I have a mute button up
Yeah,
here?
exactly.
Yeah.
Share ourselves.
No off button on the microphone would be a bad idea.
Dr. Aldretti.
There must be some kind of restrictions, though, in California for sterile compounding, because both Haggard Pharmaceuticals, which is in Lexington, Kentucky, will not compound anything for California. And there's a pharmacy in Placerville that does compounding both for human and veterinary products, and they will not do any kind of sterile compounding. So they don't even want to ship to California. So what is the restrictions for sterile compounding that makes it so difficult?
So first of all, we need to be clear that we're looking at language for us to be doing sterile compounding for use on our own animal population.
Okay.
Per patient. Okay, so this is not something that I'm going to compound for the clinic down the street or anything along those lines. It's within.
Thank you.
You know, the Board of Pharmacy, they're concerned with stability, sterility, efficacy, and consistency. And the reality is that we can answer all of those questions except sterility, because if we give the injection and it works, then we know that we've got a stable, efficacious compound. And there are 3 different forms of stability studies that the Board of Pharmacy recognizes. And one of those is experts, which we are, and anecdote, that is historical
Data.
use of a drug that it has been efficacious. And so this was one of those things we didn't know going into the meeting. We thought maybe, but they helped us dot the I's and cross the T's. And so there's still a lot out there. And again, USP is an overseeing body, and we need to make sure that we get along with all those folks as well.
Sir.
Yes, Dr. Drusis.
So as far as quality control goes, then, could it be as simple as you mix these 2 products like we've done for 30 years, and if a precipitate does not form, you're good to go? Or when a precipitate forms, you stop using it?
Yeah, we don't know that we have drilled down to that level.
Well, I mean, but you kind of get the impression from them. I mean, if we're applying the KISS principle to this whole thing, can it be that simple?
It sounded that way.
Yeah.
That's the impression I get from your description.
We probably won't use that definition.
Yeah, yeah. Okay. Anything else on compounding? Thank you, Bill, for saying nothing else.
Good plan.
Yeah.
Notice.
Yeah.
I took care of that.
Any questions from the audience? Okay, very good. That concludes agenda item number 8. Let's move back to agenda item number 7, please. A discussion and consideration of recommendations from SHAC and CVMA regarding public and private shelters and minimum standards and protocols for shelter medicine. And where we left this was with SHAC and CVMA, I think, to try and develop some language or high priority issues, and then we were going to discuss further. So an update, please.
Good morning, everyone. Thank you. So I just have a quick update. SHAC and CVMA.
Will you identify yourself,
Oh, I'm
please?
sorry. Erica Hughes, Executive Director, State Humane Association of California. Thank you. Members of SHAC and CVMA met maybe 2 months ago and had a very, very productive meeting. We are all on the same page that our primary goal is to ensure the appropriate care of animals in shelters, both animals that are owned and unowned. And we identified the need to understand understand the exact nature of the challenges that shelters face in terms of access to veterinarians and RVTs. What was really interesting was we talked a bit about the common perceptions that the veterinary profession has about shelters and vice versa, and the need to really examine those to see to what extent are those true and contributing to the issues, and to what extent are those not true, and we should be basing our decisions on those. And we really, I think we came to an agreement that there's a need to facilitate and strengthen the relationship between shelters and veterinarians, outside of this room, outside of regulations and laws, but within our industries. And so I think that is incredibly positive, because no matter what you do with regs or what you do with laws, ultimately you are left with those relationships, and those need to work in order for the animals to get the appropriate care that they need. We worked on language. We spent all day, like I said, had great conversations, and I think we've come very close to agreement. I think that in order to close the gap, we need more information about exactly why it is that shelters don't have premises permits, why, whether or not there is in fact a shortage of veterinarians willing to be on premises permits. Again, I'm not going to say that I know the answer to that question. I can tell you what the shelters say, and I can tell you what the veterinarians say, but we really need to figure that out. So at this point, we're still in the information gathering stage, and committed to making a joint recommendation that I think is based on solid facts rather than on, again, our misperceptions or our misunderstandings, or even our individual organizations' political or industry what's the word I'm looking for, agendas. So it was, I think, a very positive meeting. I learned a lot, and I'm looking forward to continuing to work with CVMA.
Questions? Do you have a time frame? Do you think, on something?
I hope to have, I need to talk with CVMA, but I'm hoping to have something, that we'll have something for the next meeting. The way that the timing of board meetings happened, we weren't able to get something done by this one.
Just a question, Erica. I think in preliminary research, there was fewer than 25 shelters that didn't have premises permits. Was that your preliminary data gathering?
That was just among the members that I surveyed and that responded to my survey.
Okay, so we
I'm
don't
sure
know
there
for
are
sure. Okay.
many more, yeah. And I am interested to know whether or not there is any way to take the data that the public can get off the website in terms of where the premises permits are, and manipulate that data and try to look at the data in other ways. Is it possible to have that done? Like we want to know within a certain geographical area who has a premises permit and who has a practice permit or whatever it's called. Sorry.
So we can order these lists by county, by city. That's probably going to be more along the lines of what you're looking for. So if you want to know by county where all the locations are,
okay,
we could send you a list in that way. In fact, we just did that for California Department of CDFA, Food and Ag, and it was for their antimicrobial resistance provisions, and they were trying to figure out where, in fact, we have veterinarians that may be able to provide, establish VCPRs and write prescriptions for food animals. And so what we did is we supplied them with a list of all the premises in the state, and we organized it by county, so they could see how many premises permits, or let's say mobile veterinarians, there were by county, and that helped them identify where we may have a access issue.
Thank you.
You're welcome.
Dr. Drusi?
Were those addresses geocoded?
What does that mean?
Latitude and longitude, so they can be plotted on a map? Probably not. So,
Again, we're the government.
we're the government. We're here to help, right? Yes.
Well, if we have the addresses, there's a simple, I think Google has a program that allows you to put it on a map.
If you don't have a program, you could do it just by typing the address in, you'll get the geocode. I could have, if I get the list, there aren't that many of them, I can have a volunteer geocode everything and plot it on a map based on counties for all of us to share.
And I think maybe it makes sense to identify, a handful of counties that everybody feels like there's a problem in, and look and see exactly what's real and what's going on in those counties and who the players are and why there's a disconnect.
You have the list, but I'll send you an email.
Yes, no, I just have the list for Riverside County.
Oh,
I can start there, but.
No, I can send you all.
Fine, fine, and we can pick out, maybe the three of us, we can pick out a couple Northern California counties, a county in the middle and a couple in the south as a beginning point. Okay?
I'm going to program you.
Any questions for Erica?
You can geocode my
Yes.
maps.
Yeah, got a couple questions. I went back through my notes to the start of when we brought this topic up, which was December of 2015. So we're moving rapidly. For us, that's pretty good. There were all in looking at all the minutes and all the notes I have, there's all types of different kinds of comments and questions that have been brought up. Rabies vaccination, premise permits, RVTs being premise permit holders. We have a wonderful letter from CVMA with some very specific language that looks good from July of last year. That's an excellent start. There was questions about redefining things in the statutes, coming up with definitions, issues with the VCPR. are you going to have recommendations in all of those areas, or do we need to be formulating some specific questions for you to answer?
I have all of those things on a list, and many, if not all of them, were addressed at the first meeting that we had. And again, I think getting a better understanding of the problem is going to dictate which one of those things goes away and which one of those things needs to be addressed.
Because some of them are resolving themselves, like some of the clarity on the veterinary assistant controlled substance issue, that's being clarified. The issue about sedating animals in a shelter environment, that seems to be working on its own also. So I'm just curious what we need to do as a committee to help keep moving this on, as opposed to just waiting for you to bring us back something. Is there any more information or direction that you need from us?
So Valerie Fenstermaker, CVMA. I just think our group that met really focused on the vaccination prophylactic control, on intake, what the potential written protocols under a supervising veterinarian could be. And while we talked about a lot of different items, and our premises task force is really addressing what we sent you was from the shelter perspective. When we talked about the written orders and those types of things, we unfolded a lot of maybe other problems that could be resolved, maybe not in regs, but I think the regulation that we will likely bring forward to you, our board meets this weekend, is more focused on what can the immediate problem of the vaccination prophylactic control and what potential written orders under a supervising veterinarian might look like. So we were trying to focus, on one thing at a time, I think.
Is that document from last July then that you're talking about?
Well,
it's a pretty good.
We use that as a starting point, okay. And I had some language that I drafted, and we looked at both of them, and then we came up with, I said what I think is pretty close. I think we're pretty close in terms of the two organizations being on board. We're just not quite there yet, and I hope to be there by the next meeting. Because I think our goal is to find something that the shelter industry and the veterinary industry agree on, and then to be able to present it to the subcommittee. And then, I'm sorry, I did forget to say that we also discussed the changes to the euthanasia reg that we would like to see, and CVMA generously offered to form a committee with us to look at the euthanasia reg, and also to look at the euthanasia curriculum to see if it needs to be updated. We haven't gotten started on that yet, but that is on the horizon.
What did you want to change in the euthanasia reg?
So the euthanasia reg says that if a non-veterinarian, non-RVT can be certified by CACTA and SHAC to teach euthanasia as long as they've met certain requirements. And one of the requirements is that they have to have taught euthanasia for 3 years, but they can't have taught euthanasia for 3 years unless they had unless they were certified to do it, and so it's this catch-22. The only euthanasia instructors we've been able to certify are ones who came from out of state where they were lawfully allowed to teach euthanasia. So we need to come up with another requirement, and then we thought it would be a good time then to look through the euthanasia curriculum to make sure that it doesn't need any updates. I know there are certain things people have mentioned, like the need to wanting to incorporate the use of mannequins in the training, which aren't mentioned in the curriculum.
Okay. Very good. Thank you.
I just also wanted to mention, just our group included shelter community. We were a small working group, a shelter veterinarian, a couple of our staff members. We asked Christy to represent the RVT profession. So I think even though it was a small working group, it was pretty inclusive of different people who could bring a lot to the table, and we had a very excellent working relationship.
So this all started with Dr. Drusi's and Dave Johnson working on kind of code. We had issues in statute and regulations that were a problem and identified just things that needed clarification, updating, et cetera. Then, Erica, you gave us a report with kind of some high priority issues that you had collected after we'd had a meeting and got a lot of input from stakeholders. And so we've got the high priority issues, the rabies, what veterinarians can do on intake, et cetera. But then we also have this whole thing about minimum standards for the premise that I don't think anybody's working on right now. We are.
Yes.
Okay. So the CVMA premise group is working on those minimum standards. Okay.
Just for clarification, minimum standards for.
Public and private shelters.
Okay.
Okay. And do we have a timeline on that, do you think, Val?
All of the premises?
Well, I know,
So
and
we
again.
thought we were done.
Okay. Okay.
But we've had to we need one more meeting. It is a really difficult project.
Yeah.
So, but we're very, very close. Anne Marie's in the group too, and we need one more meeting. Then you'll have your hands full.
And is it, both of you, do you believe that this will sit in its own little chapter of the Practice Act, that shelters will be separate? Is that how you see this language fitting into the Practice Act?
Yeah, I think so.
Yeah. Okay. That seemed to be kind of the prevailing feeling, just, yeah. Okay. Any questions? Great, thank you.
Thank you.
Any comments on this agenda item from other members in the bleachers there? Okay. Agenda item number 9. Discussion and consideration of proposed amendments regarding drug information to be provided to clients. And so we had formed a subcommittee, Dr. Sullivan and Dr. Pollard, to look into this issue that was brought to our attention at the last meeting, where perhaps veterinarians could provide more information to clients regarding drugs that are being prescribed and greater clarity. And so we asked the doctors to prepare some guidelines for us, and that's what we have in front of us, and we'll let them speak to it.
Okay. We started this with the idea that we could handle the situation through regulations, and so we did this rough draft. And in the meantime, we found out that SB 546 was going through, and once I saw that and how prescriptive it is or was, we kind of stopped developing this because it was far more prescriptive than what we have written. So I would move that we table this until we see what the statute is. I know that we have the authority to do the regulation, but if there's statute coming through, we're going to have to see what that wording is to see if we even need to do anything. And if we do, then if it is open and we need to fill in the blanks, then, then we can address it at that time. But I think we're spinning our wheels if we try to address it today. So that's I move to table this till we know what the statute, the final statutes are.
I second that.
Okay. Discussion? My concern with tabling this is that I do think that this is instructive. I mean, if you look at what is done on the human side in terms of counseling, this fits in perfectly with that. And the statute that's being considered right now by the legislature, as you noted, goes far beyond that, far beyond what's asked of on the human medical side in terms of disclosure. So I guess I'm wondering out loud whether or not discussing this and moving forward with this doesn't at least say, hey, we are more than willing to do these things. In fact, I think we do these things anyway, but we're more than willing to put it in black and white. And do we really need SB 546.
Well, if I may
Yeah,
address
please.
that, the legislature, or this Senate committee does have our draft, so they know we are working on it. What I'm saying is, I think it's futile for us to have a 15-minute or hour discussion on something that may not be necessary. And I don't mean to black hole this. I'm saying let's just table it. We've done this work thus far. It does need some refining for sure. But unless we see what's coming down legislatively, I think we're wasting time.
Question. Dick, do you know the timing of the vote on that?
I do not.
I think that they meet next week, don't they? Yeah.
So, can I make a few comments and then, okay. I did meet with Bill Gage, who is the chief consultant for the Senate Business Professions and Economic Development Committee about the bill, which is SB 546. And the bill isn't in the packet for a reason, because really the changes aren't in print yet, and the MDC's charge is not to review legislation, but to work on tasks as defined by the VMB. We did meet with him, however, so that I could share some of this work, because hopefully we can help formulate something much more reasonable for the practice of veterinary medicine. CVMA was also represented, Dr. Pulowski, Val, Dr. Grant Miller, and Christina DeCaro was there. And I think we made some headway in terms of explaining that some of these limitations in veterinary medicine are having this printed literature or knowing the risks of some of these drugs that are off-label or that are not necessarily formulated for animal use, and it's a human-modified drug. And, there were just some provisions of the bill that really weren't logical. And so we were trying to help kind of craft something that at least we can all start a really rational discussion about what should be required of veterinarians. I think everyone's in agreement that it's a good idea that there is a standard out there for veterinarians to provide drug counseling. Whether it's something you do as a matter of course of business or because you believe that that is the appropriate thing to do and we would consider that a practice standard, not everybody does it. And to the extent that, it provides some framework for us as a board to regulate when it's not done, this is helpful. We'll talk about this more tomorrow for the Veterinary Medical Board, but there is a hearing on Monday, and I would like to be able to provide some preliminary comments, maybe not a position, but necessarily something to give the committee an understanding that we are engaged, we're working on this, we think it's a good idea, but until we see language in print, I really can't ask the board to take a vote. So it is something that before the MDC meets again, we will have some probably language that looks like it's on its way. And whether or not that language is going to be supported by this group in the Veterinary Medical Board or not, that remains to be seen. But it would be feasible to say that at the next meeting, we'll see something that looks like it's going to move through the process. And I did ask if perhaps we could do something maybe more broad in statute and say, look, this is a minimum standard in veterinary medicine, and the Veterinary Medical Board shall define by regulation what the appropriate, drug counseling is. And I was turned down, so it looks like it's going to proceed through statute.
We have a motion and a second to table other discussion from the committee, and then we'll open it up to the audience. Yes.
Right, I think the issue is we're sort of, in all candor, a little bit beyond the tabling because we're kind of discussing it. And so,
if we just call it, we're not really discussing it. Yeah.
So, when we last left the saga of our hero, I think one of the things, and I'm partially responsible for these letters on the page, I think one of the things from a procedural standpoint is we were sort of offering this up as an alternative. Mm-hmm. Perhaps a statutory revision of the size and scope in 543 or whatever the bill number is wouldn't be necessary because MDC and then ultimately VMB would get there first. Mm. Okay, so obviously that really hasn't happened yet. And so, I think, with all due deference to the motion of tabling or anything, is there some message that the VMB, I'm sorry, that NBC wants to tell VMB, like, hey, this is a good start, and when, you know, when you get to talking to the legislature or the committee or whatever, you know, maybe it's a situation where, like you said, Anne Marie, you start here and you have a little more regulatory authority to kind of fine tune this or whatever. So, not that I'm not commenting on the motion itself, but I would suggest that the NBC may not want to miss an opportunity to at least tell the VMB, you know, the weather is here, wish you were beautiful, that, you know, whatever you want to say, something on this issue.
Christie and then Ellen.
Well, I guess my concern was that it would be kind of wasted if we're not going to see language. That would be my concern. If we're working against language that's out there and then we're going to get back and we're going to have to work on other language. But if it's to make a statement and say, we at least need to do something, then I would go ahead and withdraw my second. Sorry, but.
Again, I'm not on the merits, I'm just on.
No, and I understand and I appreciate all the comments and I understand what our purpose is then versus, we've already wasted the 15 minutes that we have been. But yeah, I didn't want to waste time on something that was fruitless.
It's fruitless.
Yeah, and ultimately, the NBC, just continuing on, rambling on, because I'm getting paid by the word. Ultimately, it may be that this body elects not to send any message and say, you know what, we'll just wait until perhaps it gets resolved at the higher level through statute, and then we'll tackle it, you know, then. So.
Dr. Treacy's.
I think it's important that the MDC and hence the VMB go on record as to having identified an issue and are working towards a solution, irrespective of what the political implications of pending legislation may be. It makes a very good political point to those who are voting on any other legislative piece to be able to identify that the board that's responsible for these kinds of things is doing something already, and that maybe a piece of legislation that is as extreme as most of us interpret it to be might not be necessary, especially if we can be able to contrast it or align it with what the human side has on record and currently is providing their constituency.
Does the motion still have a second?
I withdrew it.
Okay, I just wanted to be clear. Does yes?
This needs a lot of work.
Okay.
Okay, I think the emphasis needs to be changed a bit. I mean, it needs work.
Yeah.
And I don't have the inclination or energy to do work when there's something already out there. I mean,
right.
The message to the legislature from us has been sent. I don't know, it's been sent and it was ignored, and I think we've got more important things that we have to spend our time on than something we started that needs work and isn't going to go anywhere. I think we have to face reality.
Okay, from the audience, please. Okay. Oh, while Nancy's coming up, Bill.
Since we're not talking about this, one point that I really think, a huge point that stands out for me, is this term consultation. And I think it's a huge problem in this, and I hope this message gets taken up to the legislature. This means a verbal interaction, and I looked it up in 2 or 3 dictionaries, and that's what it is. There have been multiple studies, primarily done on the human side, where information given in medical offices is less than 50% retained. The other thing is some of the prescriptive things that they want said to the client with regard to this, I would question even if a veterinarian is going to have, or they're represented on the top of their tongue. Simply changing the word consultation to information, I think would be a huge benefit to this bill.
Christie?
Well, and again, since we're going to carry on then, I don't disagree, because even on the human side of this, it does not get as prescriptive as this language does. It actually says, you know, whenever the pharmacist deems it warranted in the exercise of his or her professional judgment. It leaves it open and says that they can do this when they feel it is necessary. And this is saying, you know, it constitutes unprofessional conduct for a veterinarian to fail to provide. And they have to provide all of these things each and every time. So I feel that this is really strong language, and it's not nearly what the language from the human side is. So I agree, and that's my concern with why we should have not been, you know, we can't put this forward. This is not the language we need to be putting forward. It needs a lot of work before it goes forward.
Nancy?
I subscribed to SB 546, and this morning when I looked at my emails, there was one announcing that there were amendments to the bill as of today. And I looked at it cursorily. I was getting ready to come here, and it appears that some of the stringent language has been removed.
Right.
So if you have a printed copy of the bill in your packet,
It's not on the agenda today, so we're going to talk about it tomorrow in the Veterinary Medical Board meeting. So yes, we will have the amended version available.
So it's not an accurate version of where the bill is at, and I think
We don't have the bill before us today.
Right,
It's not even in their
But I was
packets.
just suggesting that Bill Gage is very susceptible at this time to listening to what we have to say, I think. I mean, I said something to him about that this is kind of ridiculous, this is going way overboard, and he says, oh, well, you know, basically, this is just, you know, it's just a placeholder thing, and I think that we do have an opportunity to affect what that bill looks like if we make it clear that the Veterinary Medical Board is very engaged in this, and that veterinary medicine is not human medicine, and we have to, you know, we have limitations. One of my concerns was that the language of the original bill, anyway, required notifying the client of medications that were given even while the patient was in the hospital, and consulting with the owner while you're treating the animal in the hospital, which is totally impractical. And I wanted to be sure that that language came out. And I think they're trying, but the language that I saw today said except in an emergency or some other thing, but it didn't exclude a hospitalized patient. So I think that's an area that you really want to pay attention to, is making sure that you're not required to consult with clients during treatment in a hospitalized patient on every medication that you're administering.
Other comments from the audience?
Mr. Chairman, perhaps it'd be appropriate, since we're not quite sure of what the bill looks like, and maybe more restrictive or less restrictive, perhaps sort of along the lines of Dr. Sullivan is suggesting, maybe the MDC would consider deferring action until such time as the bill in its printed form comes before the board, or at least comes back here, so that we can figure out whatever it says.
Maybe a table motion.
Is it, but is there a difference between tabling an agenda item versus saying we're going to continue our work?
The real issue of the table is it takes it from discussion.
Right.
Which conspicuous by its presence is discussion. So that's the, but again, it's really what the board would say. I think you've already crossed into, you haven't drawn a second, so now the thing is before you, but it seems like there's a reluctance to act because we're working with very imperfect information. And not only are we working with imperfect information, the product that would be presumably at some point percolate up to the board itself seems flawed. So given that, perhaps defer action until we know what the bill looks like, and then maybe this is mooted out.
And by deferring action, does that need to be a tabling motion, or can we just say the work shall continue? Thank you to the subcommittee for your report.
Thank you to the subcommittee, and I think the VMB would thank, MDC would thank them for their work. It will continue on pending whatever the bill looks like.
Yeah. 6 of one, half dozen of the other, right? Yeah. David?
I was just going to move what he said.
Yeah. Any other, at this stage of the game, we recognize that there may be some things that we like and other things that we dislike with the language in front of us, and that we're not ready to formalize anything at this stage.
But we continue to move in a direction.
Right, we're moving forward, and we do actually have a serving suggestion here, which again is imperfect, but it is some language.
Correct.
Okay. So thank you, subcommittee, for your work.
So if that was a motion by David.
I don't know that we need a motion. I think we can, yeah,
We're just continuing.
So our next agenda item is we're going to break for lunch. And what time are we back?
Well, are we having the lunch brought here? Are we going over there? Okay, so,
1 hour, hour and a half?
oh, just an hour is
Hour.
fine, because they'll have our food ready.
Okay. So we're going to break for lunch, and we will meet back at 1:30. Meeting adjourned. All right, welcome back from lunch. I'd like to call the meeting to order. We are on agenda item number 10, discuss definitions and scope of responsibility for induction of anesthesia versus sedation. So this agenda item started out as informational, and basically we were trying to get some background on the difference between anesthesia and sedation as we looked to shelter practice in particular, and levels of supervision for RVTs to induce anesthesia in a shelter setting. Our minutes from last time do summarize that Dr. Druses was talking about the difference between anesthesia and sedation, and that the differences between the two are few and in some cases blend together as one continues to give a sedative and eventually it induces anesthesia. So there were 6 points that came out of that discussion. Point number 2 was from Dr. Sullivan, that we should try not to create separate standards for public shelters or private shelters versus private practice, that we should maintain the same standards of care for all animals, regardless of what building they're in. Item number 3, Ms. Laredo kept using the word exigent in a sentence.
19 or 20 times.
Yeah, it was a good one, though. I had to look it up this morning and realized that we were talking about times when we needed to get an animal sedated or under anesthesia because they had an emergency issue of some sort. Dr. Druses also was mentioning that he did not support allowing veterinary assistants to perform sedation since there's no criteria to become a veterinary assistant. I mentioned that there are a number of drugs that are classified as sedatives, but that they can actually induce anesthesia. And where we left the discussion was that we identified the potential need to allow RVTs to induce anesthesia under indirect supervision in a shelter setting. And that's where all of that wound up. And at the end of that, I decided that we should table, or the committee decided we should table that discussion for this meeting. And so now you are caught up to speed as to where we went last time. Lots of information in your packet that is basically a rehash of all of these stuff regarding anesthesia and sedation. So really where we are is taking that discussion potentially off of the table regarding the RVTs and levels of supervision in a shelter setting for inducing anesthesia. And the question is whether or not we just want to keep that on the table for right now, because we actually have a working group who's looking at this, a subcommittee that we formed, plus the SHAC CVMA subcommittee, and deferred that discussion for further for future reference, or if we want to actually delve into that a bit today. Go.
Food coma.
I'll start. I can start.
Great.
So, I have many concerns about this. I think that there is a huge difference between sedation and anesthesia. I think that the definition is different, and I think it's also defined differently in our Practice Act. I know that our committee is looking at differences between a shelter environment and what can be done for an RVT in a shelter environment, but I do not believe that it should be looking at anesthesia and sedation by an RVT without the veterinarian. And I think that we have to look at the concerns that it brings up. There is a legal concern. RVTs do not have liability insurance and cannot get liability insurance because it is not legal, and even if we made it legal, I think that there are concerns of what happens that one time that it does not go right, or it would probably be more than one time that it's not right. I think that when you look through other states, if you want to address this the same way that we asked CARV to look at their issues and ask the same questions, you look at other states, and none of the other states address anesthesia without, or sedation, without a veterinarian first looking and examining an animal. When we have talked about the emergency situations, the number one thing I hear is a matted cat. And I want to address the matted cat situation. So if that wants to be put forth as an emergency situation, first you're asking an RVT to diagnose, and you're asking them to prescribe, and then you're asking them to sedate or induce anesthesia. And what is a differential of an unkempt cat? It can be hyperthyroidism. And with hyperthyroidism, we oftentimes see cardiac changes. And then you're going to put on a cat with unknown history, you're going to put that cat under anesthesia. So you're okay with putting that cat and risking its life under anesthesia because it has mats without a veterinarian looking at it and doing an exam because you need to shave it. And I understand, I am not a heartless RVT. I care about that cat being uncomfortable because it has mats, but I think that it needs to be examined. I think that is why we have the laws that we have. And if it's that critical, then and a veterinarian needs to see it, then it needs to go to a local veterinary hospital that we contract with as a shelter, and they need to take care of it because it's an emergency situation. And if that is not something you can do, then we need to look at that. Why do we not have that relationship that we can contract those services? And that's actually something that we talked about in the subcommittee with CVMA. We need to start looking at those things and those options and quit creating exceptions to rules, because those are not emergency situations that we can keep taking out and looking at. There are emergency situations, but a matted cat is not a life-saving emergency situation. So I think that we have to start looking at this, and I really do want to make sure that we understand there is a difference between sedation and anesthesia.
Yes, Jennifer.
Christy, thank you for opening up the floor. Nobody's awake after lunch. I want to address the issue of the matted cat, because I don't think anybody is attempting to say that we need to groom. We need to do sedation or anesthesia for grooming. In my experience, the matted cat is coming in, leg matted up to its leg, maggots, you can smell it. 7:30 in the morning, the veterinarian shows up at 9 o'clock for surgery. Another experience I've seen is an animal that was maybe impounded overnight. We've all met huskies. They try to chew their way out of cages. Come in the morning, he has his jaws stuck in the cage, screaming as huskies scream. As an RVT, I don't want to feel that my hands are tied, that I can't sedate/anesthetize. And I know there's a fine line, and I don't really know where to draw that line. All of this that you were kind enough to include, it's very confusing. But I don't want anybody to think that it's just for grooming purposes. It's definitely, these are exigent circumstances. And I would hope that in the task force with SHAC and CVMA that they would be including facilities that are not, I'm very, very blessed that I work in a facility with 14 RVTs, 3 DBMs. We have access, we have officers who can transport. I know there are a lot of facilities that don't have any of that. And it is an access issue with these animals. These animals can't be left unattended. And I know, again, in Southern California, there are plenty of veterinarians that we could transport them to. There might be some areas that there is just no care anywhere. It could be the middle of the night. And I don't want to put ourselves into a situation where we can't, as licensed professionals, help these animals that are in need.
But you could sedate in that dog that has locked its jaw. That is not an illegal situation. It's not, that is, from my understanding and interpretation, because it would be, if the veterinarian has examined that dog. Am I understanding that correctly?
Yeah, there is no veterinarian at this point. The dog has been impounded in the middle of the night.
Oh, it's been impounded in the middle of the night.
I'm the first person there in the morning to find the husky screaming with his jaw stuck into the, and true, I can sedate him legally, but if I have to give him another sedative, isn't that now anesthesia? So where's the line?
Okay, Anne Marie?
So we did address some of this in the emergency care provisions under 2069, allowing an RVT to respond to an emergency with whether it be sedation or pain management, right? Whatever that controlled
Right.
substance would be. So it seems to me like the argument isn't so much what we can administer now, the argument is what defines an emergency situation. And in what circumstances would an RVT be acting under an emergency to, in fact, do what they're allowed to do in 2069 with the new provisions. And again, I go back to, this is really a shelter situation, and so I feel like our agenda is a little disjointed in that we separated it out because we thought this is a big enough issue that it needs further clarity. But if we're circling back in each one of these discussions back to the shelter environment, I think it would be more appropriate for us to discuss that as what really constitutes an emergency situation, perhaps in a shelter environment. And then are we really talking about 2069? Or are we talking about something else? Because no longer are we trying to define sedation versus anesthesia.
Right.
And as a layperson, knowing a little bit about this agenda, I can read this agenda and I'm thinking that this discussion is, hey, what is sedation, what is anesthesia, and who gets to do it? And that's not really where the conversation's going. So I don't want to play legal counsel because I'm not good at it, but I do think that we have plenty, I think we have more than enough right now. But I do think that we would be better served talking about this under the shelter heading and talking about perhaps is this emergency care situation that we've covered.
Yes, David.
This discussion will constantly go in a circle because there are components of it that are for private practice, and there are most certainly unique situations in the shelter environment that may not be an emergency as defined by 2069, which says life-threatening situations, but most certainly for the prompt and necessary veterinary care and for the health and well-being of the animal, those animals need to be sedated. But a simple low-hanging fruit for 2069 is there's no provision of those 8 tasks that are there for a technician into private practice to administer a sedative to an animal having a seizure. It talks about pharmacological agents for the control of shock, but there's nothing to talk about seizures. Well, what about the animal that's coming in and the veterinarian is at lunch and there's strychnine poisoning, or it's an epileptic. So there is some room to work within established protocols of an individual veterinary hospital. I personally have been in a situation where I sat and watched an animal in seizures until the veterinarian returned because there was no authority to treat that animal, and it's a horrible feeling. And so, yes, there are some things about 2069 that need to be brought up to standards for 2017 to help provide that necessary life-threatening care for the private sector, but most certainly not forget that there are some unique situations in the shelter environment.
So Dave, would you be recommending that really this discussion revisit 2069 as opposed to looking at specifically induction of anesthesia and sedation?
Well, I think they're two separate issues. I think 2069 needs some work in terms of pain management and seizure control. I think those are two issues that, and again, everybody always forgets that it's still up to the veterinarian to have that established authority. So if in Dr. Grant's practice, he says none of these things can occur just because the law says it, you can do it, but you're not going to do that in my practice, that is the final authority within that practice. So I think we need to look at, does 2069 need some additions to it?
Knowing that we added the latest iteration at the last meeting that does talk about pain management and sedation.
And I think those are probably appropriate upgrades.
Okay.
Now, how going anything further than that is a different discussion.
Kurt, I'll get us back on the agenda in a minute, so. Okay, we're close, we're almost there. Okay. Christy.
Well, I'm going to bring us back to the agenda right now.
Great, perfect.
You're welcome. So, speaking of sedation and anesthesia.
Yes.
It's kind of there. It's kind of there. I see a huge difference in sedation and anesthesia. And I do not see that there is any cause for an RVT to be able to perform anesthesia in an emergency situation without a veterinarian present. So I think regardless of where this goes, I think our discussion can be emergency sedation, but we should be looking at sedation and anesthesia right now, and not, because we can all talk about it. It is clearly defined in the Veterinary Practice Act. Unless you want to redefine everything in the Practice Act, it is defined.
Which
and anesthesia and what is required. Yes, it's in regs, but I think that it says in 2032.4, it would be, we're going to have to change what the requirements are for anesthesia because the veterinarian has to perform an exam within 12 hours. And so we have to make, stipulations. But I don't think that an emergency procedure should not require an RVT. It should not be required. If it's an emergency, it needs a veterinarian.
So,
to
again,
perform anesthesia.
Yes, thank you. Our agenda item is scope of responsibility for induction of anesthesia versus basically scope of responsibility for induction of sedation. Okay. And so, Christy, you've said there really isn't an emergency situation, an emergency anesthesia situation that you foresee. I mean, I'm not disagreeing with you.
My opinion.
Yes.
Yes.
And yet there may be an emergency sedation situation. Okay?
Possibly.
Possibly. And so that then kind of brings us to the tangent here of 2069 and emergency. And so this is how the 2069 does tie into this particular agenda item. And perhaps we need to continue to explore expanding 2069 in emergency services. If I paraphrase that, okay. And at that point, then, what we would need to do would be to make a recommendation to the board that we would suggest that we look at 2069 further as it relates to this and get their feedback whether or not they're interested in us pursuing that, putting that on our action item list. Any issues with that concept? Yeah.
So what you just stated is the recommendation would be to expand, elucidate, enlarge, change 2069.
Right, we would explore whether or not 2069, besides just this, the language that's been added for emergency treatment and what's allowable, if there might be an expansion of that.
If we just take the two examples that Dave and Jennifer just mentioned, I read 2069, even though it doesn't specifically specify anti-seizure medication, it says administration of pharmacological agents to prevent or control shock. And I think a seizure-ing dog, untreated, could potentially end up there. And I would take Jennifer's point about that example of the husky with his jaws clamped around the cage, maybe not responding very well to a sedative alone. And if it happens at 7:30 in the morning and she's there and it's not going to be a couple of hours before he's there, then I would look pretty critically at somebody who had the opportunity to act and didn't.
Yes, Dr. Druces.
I am really enjoying this discussion. So I know it's not written in the Practice Act, but a dose of reality from a different perspective is perhaps, at least in my mind anyway, warranted. So using any of the aforementioned examples, those of us who have to deal with the public and the animal activists, I wouldn't necessarily call them welfare people, but the activists, we are constantly criticized for either doing something or not doing something. And the examples that we're given here right this minute are excellent examples of ammunition for these people to come after us for not doing something. Now, we can have discussions from here to tomorrow about whether there should be a veterinarian on site 24 hours a day to mitigate these things. Yes, there should be, but that's grossly impractical. It's difficult enough having RVTs there for 18 hours a day. So these are situations that, from a political standpoint, can and do cause us great harm. And all I am doing, these efforts on my part, are to try to bring this out, potentially mitigate some of the downstream consequences of these situations, and stay within the parameters of good medical care, good patient care, and staying out of jail.
Or you don't get good care.
Excuse me? We don't get good care? Not unless you come to Riverside County, 'cause we're spending a lot of money there.
For your prison?
For our prisons, yes, yes.
Just as a point of clarification under 2069 on 2, I was there when we came up with this one, and medicine has changed a lot. This strictly was addressing the fact that they wanted technicians to be able to give an injection of intravenous steroids and hook them up to some lactated ringers. And that's all that section was written about. And that may not be the current standard of care. Pain medication didn't even come into the discussion at the time in 1975 and 1977. So, yes, I like your broad interpretation. That's very imaginative, but I think if that's what we think should be done, then we should really clarify that. But when that was written for administration of pharmacological agents. All they were talking about was steroids and fluids. That's all they were talking about. That was the original intent.
It's a good thing the treatment of shock has evolved.
Yes, most certainly.
Yes, Nancy.
To elaborate a little bit on what David just said, 2069 also, and the enabling legislation, 48, whatever it is, 40.5, referred to life-threatening emergencies. Now, the dog with his jaw caught in the cage, or a dog with a heavy weight on his leg so he can't move, it'd be difficult to call those life-threatening. But, so I think that we probably want to look at amending 48, 40.5, which would then allow us to amend 2069, to include serious bodily injury to life-threatening. Because I think there are many situations where serious bodily injury needs to be addressed in an emergency situation, but it's not life-threatening.
So getting back to our agenda item, which is scope of responsibility for induction versus scope of responsibility for induction of anesthesia versus induction of sedation. Have we successfully accomplished our conversation on that? It's morphed into this other thing that we really need to decide if we want to approach the board about. But does anybody have anything else they want to say about scopes of responsibility for sedation versus anesthesia at this point? Okay. So, because we need, this is a, I take credit for this, but it's a poorly written agenda item. And so it makes it challenging for us to actually have the conversation that we need to have. At this stage of the game, I will report back to the board and have a discussion with them that captures the flavor of all this other stuff we were talking about that wasn't on this agenda item. Okay? And then we'll see what the board wants to do with that. Now, Kurt can relax again. Yeah.
Mr. Chairman, just to think, so I kind of saw, we sort of had, on the spectrum, we started off with what the agenda said, and then we sort of got into sort of a setting or location-based discussion, shelter and then otherwise, and then we finally kind of morphed on over to 911 is what is your emergency kind of thing. So my presumption is going forward would be that that NBC may want to discuss this thing, but in a different parameter, which would be looking at it from the 2069 perspective and perhaps the enabling statute perspective, which we could perhaps resolve the question of induction, anesthesia, sedation by revising or refining what constitutes an emergency and perhaps even a life-threatening situation. Is that pretty much?
Yes, and making it separate from a discussion about setting. I mean, I'm a private practitioner. I have matted cats and huskies that I treat as well. And so some of those are in the clinic before I get there that morning. So this is not just a shelter setting issue. And to be able to help an animal that's in need, whether or not the veterinarian is physically present or has had a chance to look at the animal. So we do need to clarify that. But it's independent of shelter. Now we've taken that out of that conversation.
Just a final comment, and then we can wrap up.
Yes.
Okay, so final comments, we can wrap up. We brought up the enabling statute of the emergency aid situation, 4840.5, and I don't want to give Kurt any further heartburn, but when we were asked to look at this and communicate back to the legislature about emergency care, I did that. That was our charge. And it was brought up that 4840.5 has a statement that whatever treatment that the RVT is providing under the emergency care is necessary to sustain life. And the legislature found that our provisions, perhaps in what we've decided could be done under 2069, and I know Kurt had a similar concern, may be a little bit beyond that authority. And so there might be a way to correct that, or it might already be in the works because they know what the proposal was under 2069, and perhaps the 4840.5 needs to be changed so that 2069 can in fact be implemented the way it was voted on by the board.
Okay. Any other comments from the committee on this agenda item? Comments from the audience? Okey doke, moving.
we have one.
Yeah, we do, okay.
Hello again, Erica Hughes Shack. And I'm just, I guess I want clarity on BMP Code Section 4840B that allows RVTs to perform animal health care services on those animals impounded by a state, county, city, or city and county agency pursuant to the direct order, written or telephonic order of a veterinarian licensed or authorized to practice in the state. And I guess, Jennifer, to the scenario you mentioned where there's the huskies jaws locked in the cage. As an RVT, as long as your shelter has a written order or you receive a telephonic order from a veterinarian that's not present, you can sedate the animal and do what you need to do. Is that correct?
Yes, but if he doesn't respond to the sedation and I have to re-administer something, that could be bordering on anesthesia because we were trying to determine the fine line between those two.
And so is the issue here, I guess I'm unclear, and I feel like I need to have a better understanding in order to move forward with my job with CVMA, is the concern here about protecting RVTs that happen to induce anesthesia rather than sedate? Or is the issue that we want RVTs to be able to anesthetize animals? Because the way that I read the reg, it's you have to have the intent to induce anesthesia. So as long as you don't have the intent to do it, aren't you protected? Again, I don't know, is this a protect the RVT issue or is this the give RVT more authority issue?
I do want to mention that there are things that the RVT needs to be concerned about because you do not have liability coverage and you do not have certain coverage that protects you. So when there is something that goes wrong, there are things that if it is not covered in law, you will not be covered by. So there are things that, I don't know, maybe Bonnie can attest to, that RVTs need to be concerned about doing. If it is not written in law, you are not covered by it. So I want to be very careful with what we ask for. Yes, if it says that, if your intent is not to induce, be very clear about that, then you're following the law. And so, but
I guess because what I'm hearing from you in your scenario is that you may need to sedate again, but not that your intention is to induce anesthesia. Your intention is to sedate enough. You haven't adequately sedated in order to perform the procedure that you need to perform. And it seems like under the law as it is, you aren't running afoul of anything as long as you're not intending to induce anesthesia. Is that correct?
That's true. Will that hold up in court? That my intent was not to anesthetize.
Well, I mean, from my former, career as a lawyer, I think courts are very. That's what courts do. I mean, they're very experienced in ascertaining intent. I mean, criminal law is all about ascertaining intent, and that's certainly, a lot of civil statutes look at intent as well. So I don't know. I mean, I think it's going to be a matter for the trier of fact whether or not you in fact had the intent to induce anesthesia.
Because I completely understand what Christy's saying, but 7:30 in the morning, I just dropped my Starbucks on the floor, threw my purse down. I am only concerned about that animal.
Right.
I'm not thinking about liability. I want that animal to not be in pain. So I'm hesitant to back us into a corner with drawing this fine line between one and the other and creating it, writing it that now what we're doing is illegal when it wasn't before. So there's just such a fine line. But if I can just argue
But we need to make sure we don't have unintended consequences.
True, but if I just argue intent, then apparently I intended to sedate.
I don't want to say that. I'm not going to say that. I don't know.
But it'll be a question of whether you in fact did intend to sedate or not. And if you intended to sedate, but you really intended to induce anesthesia, then, then there may be evidence to show that, and you will not be covered under you won't be protected. But again, it's just going to be a question of fact.
Dr. Grant?
Not being an anesthesiologist, but speaking to a few of these guys, it is not a bright line between anesthesia and sedation. The other thing is we keep thinking it's just dose dependent and things like that. And when you see these charts, you seem to think, well, this is sedation dose, this is induced anesthesia dose. So much of that has to do with the physiologic status of that animal. Is this dehydrated? Is it old? Is there renal impairment? All of these issues come into play. So you say, I could give an equivalent dose of tilazol to two different animals and get totally different. I can almost probably kill one and the other one's fine. So it's not just the intent, it's not just the drug, it's all these other factors. I would feel comfortable, and I'm not sure if I don't know, I would defer to what Alan's or Dr. Drusi is asking, do we need anesthesia to begin with, or is sedation sufficient? And if sedation is sufficient and that was your intent, I think it would be difficult for somebody to prove otherwise that you are not sedating the animal. And I would approach it that way.
So to rewind a little bit, this conversation was across the board. It was, what's the scope of authority for a veterinary assistant or an RVT to sedate and or induce anesthesia in the shelter setting? I mean, that was how we started. And we did hear conversations a couple meetings ago about animals that needed to be anesthetized, but they had not seen a veterinarian. And this committee has walked back from that today. Okay. Before, we were just trying to figure out what the difference between sedation and anesthesia is. We don't know, because it's one of those things where you know when you see it, but it's difficult. And technically, dexdomitor is a sedative, and yet it creates such analgesia, that is pain relief, that it functions like an anesthetic agent while its class is sedative. So even the classification of the drug doesn't necessarily help us with what it does. Okay. But that was, our conversation went much farther. How much can we push this, at least in the shelter setting, these boundaries, when it clearly says induction of anesthesia in a veterinary premise, et cetera, et cetera. So again, we seem to have walked back from that, and now our conversation is talk more about emergency need of these medications. But it's been all on the table to this point. Okay.
Thank you.
Okay. So again, I will move forward with the board and have a conversation with them about emergency protocols, and I'll find some nice language that tries to clarify what the heck we just talked about. Dr. Drusi.
If the importance of an issue is measured by the length of discussion, I think this is a pretty important issue.
Yeah, yeah, indeed. Any other comments?
You like arguing with ourselves, yes.
Agenda item number 11 is the discussion of minimum standards for spay-neuter clinics. So we're kind of tackling minimum standards one by one. Obviously, we've got the fixed premises, we've got the mobile clinic, we did the vaccine clinic, and now we're up to spay-neuter clinic. This language has been hanging out in your packet here for a few meetings, and so here it is. And it's open for discussion. It is built on the platform. It's a hybrid of the fixed premise and the mobile practice, so there shouldn't be anything really unique there, but it's a serving suggestion. Yes.
Yeah, my question would be, why do we need it? If it fits into the fixed and fixed into the mobile, why wouldn't the spay and neuter clinics be one or the other and have to comply with those components?
I think that it was for clarity's sake. There were some issues where some spay-neuter clinics were being inspected, and the question is, why don't you have this, or why don't you have that particular component to your facility, and they weren't necessary.
X-ray machine would be one example.
And so it was for that practice that just does that small subset, what were the minimum standards? That's why.
Okay.
Yeah. That's Dr. Grant.
We have a spay-neuter clinic, and we were inspected in the last year, and the standards don't fit for what we do. Postings of things like keeping animals overnight, isolation, X-ray, all kinds of different things that aren't there. I had a question, just to be sure, with our changes in establishing a VCPR, and I've had a brief discussion with Anne Marie about this. What happens in a lot of vaccine clinics are animals are dropped off early in the morning. People work, and they're dropped off usually between 7:30, something like that. They sign a form which authorizes the veterinarian to perform a spay-neuter procedure. And the animals are examined by the veterinarian prior to surgery. Surgeries were performed. The animal comes back, the owner comes back, picks up the animal, and that's what occurs. That establishment of a VCPR, even though, and I know we had extensive discussion that the change really had to do with telemedicine with an in-person establishment of a VCPR, that in-person intent of that change would be fine with doing a physical exam and establishing the VCPR.
John?
Yes.
Yeah, now I know where you're going. I didn't understand our conversation earlier. But the telemedicine definition is a virtual exam is the key. For forever, people have been dropping off animals that are sick and going to work, and then the veterinarian examines them, calls them. So that's, in my opinion, perfectly fine. Examination is an animal exam, not in client exam.
Exactly.
So
Right.
what the telemedicine issue is that virtual exam, which we're trying to stay away from.
And one step further, if there's something wrong, i.e. cryptorchid, umbilical hernia, there's always a conversation with the owner prior to any surgery or anything else. Or a big one is deciduous teeth. There's 3 or 4 deciduous teeth. Do you want us to do that? And that's it. The next question I had is number 3. It says a collection tank for disposal of waste material. I'm not sure what type of waste material you were talking about here, and if it has to do with parts removed from the animal. A lot of times those are actually put in a freezer, and it's not necessarily a collection tank.
It's exactly the same collection tank that's in the mobile clinic language. So it's whatever that collection tank was, this is the same one. Yeah.
I still don't know what that means.
Freezer, trash can.
Yeah, that's what he just said.
Yeah. Well, when we updated mobile, but we didn't originally, this group didn't ever originally write that, so I'm not sure what they mean by, maybe waste material did have to do with feces and things like that, because it's a mobile clinic. So we probably wouldn't need that if that's the case. We could probably strike number 3.
Yep,
okay.
Sure.
So just for clarification, if I may, you were inspected and you said a lot of things don't fit. Well, that's not unique to just spay and neuter clinics. We're seeing that across the board, large animal especially.
Right.
And when that occurs, our inspectors are not, non-applicable provisions. You're not being written up for failure to meet minimum standards. It's just not applicable to the premises in which these standards would otherwise apply.
All due respect, we were written up for it. And and the form was changed when I explained it to him.
Well, we have 3 separate forms that are out there, so, okay. I think that we're talking about 2 separate things, because I don't see small animal spay and neuter clinic any different than what we encounter, as I said, in the field with other kind of specialty area practices that don't do all veterinary medicine. And so they wouldn't have to meet the minimum standards. And this is something that we've been talking about as a committee with CVMA for some time, looking at all of these different specialty practices. So are we going to start creating minimum standards for each and every one of these specialty practices? And if so, you know, I guess that's the road we're going down. But I don't really see what makes spay and neuter different than some of these other practices that we're already tailoring our inspection for.
And I agree. I think that's a great discussion. I'm not sure that you have to. You go to an ophthalmologist office, it's
Right.
going to be totally different than my fixed practice. And yet they're going to be inspected as a small animal fixed premises.
Right.
I get that, but the experience that we had, I mean, there were things that were checked off on the form as not passing.
Mm-hmm.
And it was, I don't want to say an argument, but it was a discussion, we'll say, of why I don't think that that is pertinent.
So was it because you're a surgery, because it's a surgery and you were expected to meet the surgery standards? In terms of your surgery suite, your anesthetic machines, I mean, really it gets down to.
No, all of that was there.
Okay. We should have a side conversation.
Okay. Kurt?
So there's no truth to the rumor that my middle name is Wet Blanket, but I'm a little bit perplexed because number 10, we had sort of a oblique agenda item, and I'm just trying to figure out what the anticipated outcome in all candor is for number 11, because 11 is agendized as discuss minimum standards. So is there an output here that I'm not aware of? Because I know the agenda in the small print says action can be taken on any item but are we anticipating trying to set this for regulatory hearing and the recommendation to the board, or what? I'm just want to make sure that we got enough room under the agenda to do that sort of thing.
I think we're trying to decide today whether or not this is a necessary method to address maybe some unique practice settings that don't meet all of the minimum standards. And so looking at these set of standards, as our subcommittee of one, Dr. Klingborg, so graciously put together. And again, I apologize for not putting headings on these, because Christy, you've brought this up in the past, and I need to put headings on these documents so you know where they came from. But this is a subcommittee output that said, okay, if we're going to go down the road to look at what minimum standards should be for spay and neuter clinics, unique from other veterinary practices, here's a shot in the dark as to, it's more than a shot in the dark, but as to where we could start. And now the discussion has gone to, is this necessary? So I disagree that we're off topic. I think we're trying to decide, should there be an output to this? Or have we've now looked at the language and said, perhaps this really isn't unique, it's just how we inspect needs to be specific to the standards for the practice.
There is, I'll get to you in a minute, Ellen. There is one key here, and that's E, and that's the discussion about the after-hours emergency. And that's really what sets this apart from the fixed practice, is that piece of language. And there are issues where these emergency, or these spay-neuter clinics, animals in and out the same day, animals not doing well that night, clinic is closed. And so that's a key piece to this conversation, and why that minimum standard was brought kind of to light with a little bit more clarity. Dr. Druces, Dr. Grant, Dr. Sullivan.
Okay, so with respect to Dr. Grant's recent experience with an inspector, so our facilities have been inspected too many times from my standpoint. Nevertheless, the door is always open.
Oh, thank you.
So, one of the first inspections, certainly, medical records were an issue. We provided a glimpse into the medical records of the animals that happened to be there then, and then some more information was requested. So I said, give me a 7-digit number beginning with 13, and pick any animal you want and look at that medical record. And so what came up was, so we impound about 50,000 animals a year. And nobody there can examine, there's not a veterinarian that can examine every single one of them. And a lot of them, from our perspective, a shelter perspective, are NSF, no significant findings. And that was found to be inadequate from the inspector's point of view. And I said, when 30,000 of the 50,000 are, from our perspective, not significant findings, I can't employ anybody to spend all day long putting a soap in that says essentially NSF. So it took a little, it was a learning curve, but I believe that that's an example of the inspection process that does not fit a shelter or a small animal spay-neuter clinic. The other thing, are we married to the term clinic here? I actually never like that, although everybody uses it. I mean, to me, spay-neuter facility might be a better description of it. Clinic implies, I think, more medical practice than what actually occurs at a spay-neuter facility. Third thing, establish a VCPR. So last year we did 15,756 surgeries. About a third of them were on owned animals. The other 2/3 were on shelter animals. The animals contained within our shelters are not the county's, they're not ours, we never own them. We are a or a depository. I can always forget whether it's an R.
You're a
Anyway,
deposit.
I'm a deposit, yes. So, with whom is our VCPR?
You don't need one, because it's on an unknown animal.
But yet it's in here on the facility. Well, no, they are owned. Scotty didn't beam these things down.
Their animals are considered under the Hayden Act, and they're not
They
considered.
have owned
known-
animals.
Doesn't matter.
Yes, we do.
They're still owned.
They're saying a majority of the spay and neuters that they do are not on owned animals.
2/3, but 1/3
Right,
are.
right,
Yes.
and so we're talking about the 2/3 that aren't. The 1/3 that are, you're gonna have to establish a VCPR.
We do, yes,
Right.
we do that.
So
But
he's
the-
asking about the 2/3 that aren't.
But it says veterinarians shall establish a VCPR.
So you have to read that in conjunction with the other statutes. This isn't a standalone, so there are statutes that cover the Hayden Act, and also there are statutes within the Veterinary Medicine Practice Act that talk about unknown animals. Yeah. So you have to read these things in concert with one another. This isn't a standalone provision.
Dr. Grant, Dr. Sullivan, then Dr. Pollard.
We can come back to him.
You can come back. I'll table that for a second.
You lost it.
A wise course of action.
I was just gonna comment that item E, every
Oh, I know.
clinic requires that.
No, you remember.
Yeah, I mean, it's not specific to spay and neuter.
Well, yes, but if we were going to create language for a spay-neuter clinic, we want to make sure that we've captured all of the elements. So we've got two possibilities here. We can just have all of these fixed premises standards and then allow the inspector to pick and choose. Or we can try and define for every potential subset of practice. And there is one state that has broken the standards down and says grab A, B, and E, and that's for a large animal facility, and A, B, and Q, and that's for a small animal facility. And so there are some that do this as some kind of puzzle piece type of thing. I mean, that's the possibility. So we can either just say, hey, our fixed standards are fine, even though they didn't work great for in Dr. Grant's case, at least not until you had a conversation. And that would be much simpler, but that puts it all on the burden of the inspector and on the individual that's the managing licensee of the practice that then may have to defend the way the inspection came out. I'm sorry, sir, you're at the end of the line. Dr. Pollard, Mr. Johnson, and then Dr. Grant.
I'll forget mine.
Write it down.
Write a note.
Yeah.
Mine is short because,
Now he's gonna forget.
because Dick stole my thunder. I just was going to point out E2 just because of the way John phrased it as this was added when in fact it's part of the fixed practice
Yeah.
facility too.
Thank you. I too have had numerous inspections, and one size does not fit all. There were things that just don't apply to the shelters, but the inspector understood that and seemed to have the latitude to not consider that a violation. I realize that what we have in our handout today is just a draft, but what I'm curious about is if we go that direction, there were some real significant statements in our existing minimum standards that were left out, and some of them are very significant regardless of the fact that it's just a spay-neuter facility. There's things about aseptic technique and what personnel wear and emergency oxygen and all those things that should still apply. So I'm kind of curious if we go that route, we should just take the language directly out of 2030 and remove those things that don't apply to just a spay-neuter. But I know of one of our spay-neuter facilities in San Diego, in addition to spay-neuter, they do vaccinations, diagnostic testing, prescriptions of medications, and so now, does that put them in a hybrid spay-neuter clinic situation, or are they a fixed premise? And I'm more comfortable with having everyone adhere to the fixed premise because so much work has gone into that. It's very well defined, and then having the inspectors have the authority and the understanding that depending upon the situation they're inspecting, there may be situations where every single one does not apply.
Okay. Dr. Grant?
There is hybrids, just as Dr. Johnson pointed out, of this. There are a number of mobile spay-neuter clinics.
Well, yours is a hybrid,
No, we're fixed. It's a fixed premise.
but you also have the vaccination clinic in the spay and neuter clinic.
Are
as well.
together, and there's no diagnostics, there's no dangerous drugs, anything else. Anything that comes out, say there's a dog that had something wrong and it needed an antibiotic, it actually, the antibiotic would come from the fixed premise, the full facility with all of that information on it. And as a matter of fact too, you know, we talk about E. Actually, in fixed premises, that's fine, I think, what's there, because it does, at the spay-neuter, or the vaccine clinic and spay-neuter clinic, it's referred back to the hospital, and if the hospital's closed, it's referred to the emergency clinic. And we had to go through that to be sure. Now, the ones that are mobile, a lot of them are in Los Angeles. Those all have handouts with local emergency clinics, and they all get that. We also have a handout that tells post-op care and all of that. So, I mean, do I think, just because we had an experience that everything didn't fit, you know, that we need to reinvent the wheel, the answer is no. And if I'm fine with leaving it the way it is, as long as somebody that comes in does have the wherewithal to say, look, this fits, that doesn't fit, and that's how we inspect the facility.
Yes, Emery.
Well, you know, I say all this, and Val and I'm sure our stomachs are turning because what we, and Ken, because what we're doing, Christy, and Dr. Sullivan, what we're doing as far as the task force is we are looking at some unique standards, primarily though because large animal just really doesn't fit in a lot of this. And we have things that are ambulatory versus mobile, and mobile and ambulatory are two different things. So because we're not parsing out spay and neuter doesn't mean we don't need to do something that's a little more formative for these other very different practice types. that we have a really difficult time from an inspection standpoint going out to a barn and applying any standards whatsoever because nothing fits well. And that's what we're finding out in doing this homework and really laboriously looking at this language and trying to figure out what's the right method for us so that we ensure that there is some bar, but that we're not trying to make things fit for a practice type that has no place, having non-porous doors and walls and ceilings, and we're talking about a barn. So I think that in this situation, you're a brick and mortar facility. And perhaps when we're talking about an actual facility where the clients are bringing their patients to you and you're providing some level of veterinary care, I think there's something already there that we use. In other situations where we may be going to someone's house, we may be going to a third-party location, we may be going to a barn, we definitely have some work to do. I don't see this personally doing the work that we've done on the task force as necessitating that level of scrutiny. But that's just my opinion.
I agree.
So this agenda item is our own darn fault because we actually asked the board if we could look at this. And they said, yes, you may. So we have looked at this, and the action item that comes out of here may be that we reject this language and move forward. And that would be fine, but that would need to be a motion and a second and all the rest of it. Yeah.
So with respect to the inspection process or the inspectors, the training of the hospital inspectors includes an appreciation of the different, in this case, small animal practice locations?
So yes, in fact, I attend hospital inspector training, and we talk about some of these not one-size-fits-all scenarios, and there's more not one-size-fits-all than there is actually one-size-fits-all scenarios that they encounter. Several of our board members have been on inspections, and Kathy's nodding her head because she's actually gone out with one of our local to the Northern California area, and he does go to shelters, and he does go to spay and neuter clinics, and he does apply minimum standards. And because they're trained to note that if this is not the practice type of this particular location, you're not going to see these standards, you're not going to be able to check for these standards. But whatever that location does do, you have to inspect records. And you're going to know when you inspect those records, are they doing more than what they're telling you they're doing? By virtue of going in and doing a random inspection of records. You're also looking at their equipment. So, I can't say for certain there's not inspectors out there that perhaps don't understand that nuance, but I can tell you that it's part of our training.
Motion time. Yep.
I move that we recommend that we not continue forward with minimum standards for spay-neuter clinics.
I'll second that.
That's the most enthusiastic he's been all day.
Wow.
I just woke up.
Any discussion?
No.
Discussion from the
We're in
audience?
trouble now.
So we'll get you to call.
Okay.
Yep, yes?
I just have one point.
Yep.
May I speak?
Sure, please do.
Yeah, there's not a forum.
I just have one comment. I am Cheryl Waterhouse. I know of, unfortunately, one facility that is a spay-neuter clinic, a fixed premise, that does not have individual compartments for each animal that comes in for surgery. And there may be 20, 30, 40 animals in one big room.
Wow.
Which I don't think is appropriate. And so I just throw that out there that this is going on. And in light of your last motions, this may not fit at all, but I hope that the board may look at that and however you decide that fits.
So, yeah, without straying too far off topic, we have looked at the separation of animals and compartments. I'm going to duck because he can't look at me and give me dirty looks, but yes, that is something we've talked about.
Any other comments from the public?
Bonnie Lutz. This is probably just duplicative and summarizing, but from my perspective, I think you made the absolute right decision, because what I see are my clients now wanting to nuance these special regulations that you've got for different, you got spay and neuter, you got vaccine clinic, and once somebody gets it in their head that they're gonna fit this little box, but then they kind of add other things that they're gonna do, that's a real problem for me. I also do regulatory work for a large pet store, and so that's a challenge, as you can imagine. So I think you made the absolute right decision, but I do think we need standards for large animal. The other thing is that, and when I've been involved in defending against an inspection that sort of was bad because they were checking the box when they shouldn't have, my experience has been that once I write the letter, the board says fine. I mean, I've never had the board continue to go after my client who didn't have anything, something that he should have had when he didn't even do that, so.
Thanks, Bonnie, but we haven't voted yet, so this could come out. We don't know what's going to happen. Any other comments? All right, let's vote.
Dr. Klingborg.
Aye.
Dr. Druces.
Aye.
Dr. Grant.
Aye.
Dr. Pollard.
Aye.
Dave Johnson.
Aye.
Christy Pulowski.
Yes.
Jennifer Laredo. Sure. Dr. Sullivan.
Aye.
Motion carries. 15-minute break. We'll be back at 2:55. Okay, let's come back to order.
Same thing.
I mailed, no, I mailed federal.
Yeah, I mailed federal.
I always get back from the state, and I pay the exact same amount to the federal.
Where's your gavel?
I'm in the exact
It's a cash flow deal.
Agenda item number 12. Discuss the minimum standards for mobile specialists. Dr. Bill Grant was the subcommittee for this. So, without further ado, Dr. Grant.
Thank you, Dr. Klingborg. We had a great informative discussion with my committee of one.
With yourself, that is, right?
That's how most of his discussions.
There were disagreements. That was several arguments that lasted quite some time. Anyway, this was a discussion that Anne Marie and I had regarding handing off cases to mobile specialists. And I think there was an attempt to see if we could place some of the responsibility with one individual or another. And I had discussions with 3 MDs because I know that they have a lot of interaction with each specialty or subspecialty, about 40 different veterinarians and 2 mobile specialists. And the more we talked about it, the more we looked at it, because there is such great interaction and each case is really different and individual, at least what I saw, I didn't think that we could define certain areas of responsibility and make a bright line determination on any of them. So if I listed a number of the issues to consider: pre-op evaluation, examination, diagnosis, treatment protocols, are they all communicated? Prognosis, anesthesia, if they're in a fixed facility and you've got a tech and the tech works for the fixed facility, but the surgeon is doing the surgery, who's really responsible? Establishing the VCPR, transfer the VCPR. I talked to, as I said, 2 mobile specialists, and I was quite surprised. These 2 individuals, they speak to the client, and that's, I thought, somewhat unusual. I assumed that a lot of mobile specialists, they come in, they don't want to talk to the client, they want to get in, they want to get out, and move on to the next clinic. But both were surgeons, and both said they want to be sure that the client has a expectation of what the potential outcomes and complications are with their procedure. So I thought that was very good. Anesthesia recovery, post-op care. You're probably aware there's a very large case that had to do with a declaw of 2 cats, and the discussion was when the problems with the feet came up, was it due to the surgery or was it due to the bandages? And unfortunately, there was back and forth between the two, because the surgeon was a relief doctor that came into the facility, and the fixed facility stayed and took care of the bandages afterwards for several times, and each veterinarian didn't think that they were responsible for the negative outcome that came to that. And that has turned into a very, very costly case, a very unfortunate outcome for a couple of cats, and that's why I say making a bright line determination on some of these issues, I just don't think can be done. So that's what I came up with. Unfortunately, I don't see it's something that I think we really have the opportunity to do a whole lot with by statute or regulation.
Questions for Dr. Grant? I did look on the human side for any kind of direction there. There really isn't. I mean, good veterinary practice would dictate you communicate with the client, so.
Right. We have a mobile ultrasonographer. I don't think she's talked to a single client, but I don't think she needs to. Mobile surgeon, that's a whole different situation. And, you know, I think there are more and more, as more specialists have come into private practice and have gone away from the university setting, you know, this is going to be an ongoing issue. Dr. Pollard and I did review at our last review a case that they had 3 or 4 veterinarians involved in the case, and the board brought all 4 of them in, looked at records and participation and statements from all of them. And I think at the end of the day, the board made the right decision with who they held responsible for the case. So I think it's being done. In fact, I know it's being done, and I think they're doing a good job. There's just not an easy solution to the problem.
So you were asked to look at this. Do you feel that you've satisfied?
I've satisfied my committee.
Okay. Very good. Yeah. Well, at least you agree with yourself about that.
That's a challenge.
Yeah, I'm impressed. I won't ask him again. His opinion may change. Any questions from the audience? Comments? Okay. Well, we will move forward with our next agenda item, which is item 13, review, discussion, and possible recommendation on reciprocity issues and license eligibility for veterinary applicants. I know that we've had legal counsel involved in this, also Anne Marie. I don't know who wants to give us some background here as we kind of tackle this complicated issue.
Start and then turn it over to you.
I'm sorry?
Or do you want to just go with it? No? You want me to roll? Okay. Okay, so this issue is in front of the MDC because it was an issue that the Veterinary Medical Board was dealing with in looking at qualifications for licensure and examining eligibility for reciprocity. And we recently had a few cases where we've had individuals who applied for a veterinary license who their professional experience was in a foreign country, that being outside of the United States territory, or Canada. And according to the read of the statute and how the statute's been interpreted, and we brought it back before the board and we got agreement from the board, this is how they interpret the statute and how they expect us to apply the statute. We were requested, we being the MDC, to look at perhaps equivalent eligibility standards, that being board certification, as a pathway to equivalency. So Diana Woodward-Hagel was charged as the subcommittee of one, and again, the document that's in your packet should be labeled accordingly, to look at whether or not there are parallels in the Medical Practices Act or any other Practices Act for that regard, along the lines of establishing an equivalency for reciprocity. I do, however, before we go down the road of looking at Diana's work, I want to talk to you about the legal analysis that Tara Welch has done for us in terms of looking at legislative history and perhaps intent. And I also want to mention that there is a bill out there currently that would address foreign-trained applicants in terms of removing barriers to licensure for individuals that are foreign-trained. So this is a movement in the legislature. The Little Hoover Commission has expressed expressed some, I don't want to say concern, but motivation behind looking at every one of our licensing requirements to determine whether or not they are in fact necessary to establish a entry-level standard that, would in fact protect the public. And that if there are requirements that currently exist that are there perhaps as more of a barrier than a necessity to establish minimum care or minimum standards for a practice, then we need to examine those and think about whether or not they should be removed. So I just want to give you a little bit of the backdrop about some of the motivation currently in the political climate, and then I'd like Tara to talk to you about her research.
While we wait for Ms. Welch to come, I'm going to play my attorney role on TV. So there's a couple things I think.
Sorry, Tara.
I think just to fill in something, Anne Marie, if I recollect correctly, the board instructed, sought to have this issue at least preliminary fixed by statute.
Correct.
Okay.
Correct.
And so, having been former on the human side, medical board counsel, there was essentially the medical board of California sort of, when I was a counsel, sort of had two lines of thinking. Either something, as far as schools, something was accredited by the LCME, which meant our friends in Canada and a few others. And if that was good, you were golden. You got 1 year of postgraduate training and you could be eligible for licensure as a physician. If you were a foreign medical grad by one of our schools that was accredited, it was 2 years of postgrad and then you were eligible for licensure. And the legislature has essentially manipulated that scheme. So, Anne Marie, as you pointed out, a movement, there has been a movement on the human side already. So I think to some extent the issue here was did the board want to recognize board certification as somehow satisfying some of these eligibility requirements? And I think that is the issue before the MDC is there a need? Is there an access issue? Is this an insurmountable barrier to entry? Does this reduce the potential number of qualified veterinarians that can practice safely and competently in the state of California if we were to allow like the substitution of some of this clinical practice by board certification? I think that's a salient issue. Okay, having said that, I'm going to shut up. So, Ms. Walsh, anything to add there?
Not on board certification per se, but just in so far as reciprocity goes in general. So just the backdrop is all I'm providing. Prior to 1998, the Practice Act required licensure in one or more states and having lawfully and continuously engaged in the practice of veterinary medicine for 4 years or more in one or more states, preceding applying to the board for licensure. So in 1998, though, the legislature revised the statutes to start to incorporate a reciprocity statute. In doing so, they took two separate paragraphs and combined them into one. So the statute now reads that if you are licensed in Canada, another state, or territory of the U.S., and you have a certain amount of clinical experience, then you can qualify for examination waiver. You can also, if you meet specified criteria, one of which is having licensure in another state, Canada, U.S. territory, and the experience, plus a few other factors, you can get a temporary license. The way the board has understood the statutes forever is that the statute itself still requires that experience to be in a recognized effectively location. So at this point, it would be Canada, U.S., states, and territories. To the extent that the board is now receiving applications from individuals who are actually receiving their practice in other countries, that's really, I think, a murky area right now that the board will need to address either through statute, to the extent the board wants clarification from the legislature as to what experience satisfies the statute insofar as it diverges from the board's interpretation of the statute. Separately, the board could take a look at regulation and maybe make some modifications there.
Yes, Dr. Sullivan.
Well, I think I've mentioned this before. I have practiced in another country, and clinical practice in other countries are not the same as they are in these criteria, Canada, U.S. or U.S. territories. And I think that the specification is very specific, is to the point of the type of clinical experience that person is coming to this state with. It's reciprocity. It's not, they're asking to come in. It's not as if they don't have other choices in their lives. Most of these people have licenses in other states, so we're not depriving them of their livelihood. And I was around when this was written. It was written for a very specific reason, and I'm having trouble with the justification of changing it. I like the way it is.
A couple of things. First, a shout out to my dad, Dr. Don Klingborg, who went crazy with this issue when he was active in veterinary politics in the state, calling it uniprocity, because we're allowing people into the state, but those states weren't returning the favor to California graduates. And a lot of that stemmed from the fact that state boards in other states were not that hard to pass, with a greater than 97% pass rate in many of them. Also, Tara had mentioned the 4 years of practice, which gradually was eroded. It was working 4 of the past 5 years, and gradually has been whittled down now to 2 years. The idea behind all those years was that if somebody was incompetent, perhaps the licensing board could have caught up to them in that time frame, such that while that wasn't a complete assurance of quality, it was one tool for quality control. So the third part here to this is that the board did vote and pass a motion at the last meeting, and that's not in here, regarding adding language here about the U.S. state, Canadian province, or United States territory. The experience. And so that would be has practiced clinical veterinary medicine for a minimum of 2 years, and then did the language go there, or was it at the very end of that?
I think if I can be so bold, I think it was to follow that the experience had to be gathered in a U.S. state, Canadian province, or U.S. territory, if I recall correctly.
Okay.
And it's actually paragraph 1, 2, 3, 4, 5 of your memo. It says the board discussed the issue at their January 2017 meeting and clarified it is the board's intent that the clinical experience for the purposes of reciprocity eligibility must be in another U.S. state, Canadian province, or U.S. territory. So while it's not language exactly, that was the motion, and so it was captured in the memo.
That was a bold motion. That was the word that was used at the board meeting, bold. So thank you, board, for boldly voting to send this to the MDC. Yeah. And then we have the memo from Diana Woodward Hagel, and she really does talk about the fact, and actually it was interesting because Kurt also had referenced this at the board meeting, that we have 3 separate components to this language here. We've got that there's a license in good standing in another state, Canadian province, or United States territory. We've got that has practiced veterinary medicine, and that there was a minimum of 2,944 hours of clinical practice. Again, wasn't specified where that practice was at that point. So at this stage of the game, we're tasked really with the question whether or not there should be some special consideration for those whom are board certified. That is my understanding of today's mission. Okay. And so that's open floor. Yep, Dr. Drusius.
Couple things. No mention is made here that I could see with respect to PAVE or ECFVG certification. For the longest time, there were a number of states that did not require ECFVG. It didn't require anything. I know specifically of a classmate that was a year behind me in Berlin, grew up in Ohio, went back to Ohio, never took the Ohio boards, but never took any ECFVG or PAVE certification. And if I interpret this correctly, she's still in practice. Now this state, unless things have changed, would require otherwise a PAVE or ECFVG certificate, but she may not, having been a longtime resident practitioner in Ohio. Is that something that we want to accept? Number one.
Clarify the scenario. This is a person that worked in Ohio for a number of years, but hasn't worked for the last.
No, is still working, to my knowledge, in
And a
Ohio.
license, but she would already qualify for a license under reciprocity.
Even though she never did PAVE or
Right.
ECFVG?
Right.
What's the timeline then for not having completed PAVE or ECFVG?
There isn't.
She satisfied Ohio's
satisfied,
requirement at
yeah.
that time.
Yeah.
So the fact that she's worked there the 5 years,
Right.
or the minimum 2,944 hours now is a moot point.
Right.
Yeah.
So there are, in 4848, there are a number of pathways for waiver and temporary licensure.
Okay. Fine, if that, I don't have a problem with it. I mean, I just want to bring that to everybody's attention. The other thing is, what type of board certification?
Doesn't say.
I know it doesn't say, and with all due respect to diplomats or diplomates, there's a difference between a clinical practice specialty and practicing clinical medicine and surgery and something like microbiology. When I was on the ECFVG, I never got to see the passing scores from the clinical proficiency exam. I only saw the appeals on failures, and we had a couple. One was a dermatologist and one was a microbiologist that, my estimation, grossly did not pass the clinical proficiency exam. That if I understand things here today, even though one was a boarded microbiologist, one was a boarded dermatologist, they would satisfy the requirement.
Question to that point, would they be practicing in their specialty?
And that's,
No, in California.
Well,
That seems to be the intent. So if they do, you wouldn't want a board certified, anything currently in 2017 to be practicing outside of their specialty, nor would they want.
Right. But that, and this is a good conversation to have, because the concept wasn't limited to that if they got a license in California, it's going to be a limited license.
It was not that.
No. So if you think about licensure, it doesn't limit you to only practice a specialty area of veterinary medicine. You get a license to practice veterinary medicine across the board.
Got it.
Yeah.
Jennifer?
Just to that point, there was some discussion at the board meeting and some concern about that, because I've been in situations where I'll ask a board-certified doctor in one area a question regarding another area, and they give me that look, and we would have no way to restrict them from general practice. They would become, even though they're boarded in dermatology, they would be able to perform surgery on horses or whatever it may be.
Dr. Sullivan?
Yeah, I'm always concerned when we start carving out exemptions, because the intent was to have a certain amount of experience, clinical experience, and it's spelled out, at least to me, very clearly. And if we start carving them out, I think we lose credibility, we lose control of that clinical experience. And I think it's going down the wrong road, even for a specialist.
Dr. Grant?
Yeah, I agree, and we have in Orange County a couple of people. One is a boarded microbiologist that's now practicing general practice, and an equine guy was an equine surgeon and got tired of getting beat up and everything else, and is now doing small animal also. And to waive requirements for that, I totally disagree.
So just want to comment about things that we look at from a board perspective, which is an undue hardship for an individual to obtain a license. And again, this is about equivalency, and it speaks to the need for an examination. So this doesn't say that these individuals who've been practicing in a foreign territory are ineligible from practicing in California. They just have to meet the entry-level standards, and that means take an exam. So I don't want that to be lost, that on the committee, the discussion, or for the purposes of those that are tuning in, that this is not to say that these individuals don't have a pathway to licensure. They just don't have an equivalency pathway to licensure. They can take the exam, they can essentially still apply under the traditional path.
Mr. Delmonico, can I just elaborate on just a second? So just to make the record clear, this is, the practice here is, it's not a bar.
Right.
Not a bar licensure.
Right.
And then to take the necessary examination, they are not precluded.
Right, exactly.
Okay, so the foreign experience does not serve as a bar, and it does not prevent them from sitting for the necessary exam.
Correct.
Okay.
And I think the key point that you said was entry level. This is entry level. I don't see what problem there really should be with an entry level exam.
Well, I think for some people who've been practicing for many years, and I think we've had a couple of people that will go nameless that have actually said, hey, if I had to go back and take the NAVLE again, I'm not so sure that I'd fare well on it, because it's been, 20 years since I graduated from veterinary school. So you're looking at Alan, it wasn't Alan.
35 years later.
But, I think that's what some of these individuals are concerned about, is that they've been out of school for so long, yet they've been practicing, albeit not in a U.S. territory, that to sit for an entry-level exam based on the, most current curriculum may not be as easy as one might think.
And the experience at the ECFEG bears that out. There are hurdles that need to be overcome for people that have been out of school for a while.
So Diana did a nice job of kind of breaking down 6 different issues for us, which is page 2 of her memo. And the first one, I think that the board handled already by including the intent or language that the clinical practice needed to be within U.S. or Canada or U.S. territories. And again, she, in the second one, provided the remedy to the first one. So 1 and 2 are addressed. In number 3, she asks, would it be good policy to allow board-certified veterinarians to be exempted from some or all of the clinical practice requirements? And what I've heard this committee saying is, we don't think so. Item number 4, and we'll get to the public in a minute if there are comments, but item number 4, no specific mention is made of board certification in the statute unless there's this reference to specialty board training. And I'm honestly not sure where she's seeing that, what that's in reference to.
I think if you look at, Dr. Klingberg, I think if you look at the statute, it says, experience obtained while participating in AVMA, accredited institution, internship, residency, or specialty board training program shall be valid for meeting the minimum experience requirement. So I think that's where that comes from. Conspicuous by its absence is actual board certification, though, which I think, given the legislature, if you look at the medical board and other statutes, knows what board certification means. So had they wanted to put it in here, I think they certainly could have.
Isn't specialty board training, though, a lower bar than board certification?
I'm not sure what specialty board training is. It could be something that, you know, the specialty board
Residency.
offers on a periodic basis, not leading to anything. So, I mean,
Okay. And then she asks in item 5, is it important to require that some or all of the applicant's previous clinical practice be exclusively in that specialty? Again, it doesn't sound like we're really interested in going down that road. Item number 6, although incorporating board certification into a licensing application statute may appear to be good policy, it also means that the board is losing control over some aspects of its licensing requirements. I did spend some time looking at AVMA board certification, and it does vary widely between orthopedics versus behavior and nutrition and et cetera.
Shelter medicine.
Yeah. So there's just a lot of variability there. So at the end of this, we're tasked by the board, I think, to consider this issue and make a determination. What do you all think? Yes, Dr. Sullivan.
I move that well, wait a second, did we already, at the board level, we've already made that change? So I would move that we do not add anything different to the statute, I guess it is, than what we've already done at the last board meeting.
so if I can paraphrase there, Dr. Sullivan, if I may, I guess this motion would be successful, would really mean that this committee would recommend to the board that it not consider recognizing specialty board certification as satisfying the clinical experience requirement.
So moved.
Second.
Dr. Sullivan seconded. Okay.
It does.
Comment?
We can switch if you want.
It's okay. Discussion? Discussion from the public? President Pawlowski.
Yes. Yes, Chair Klingborg, thank you. I mean, just kind of aside, but going back to Dr. Drusey's comment, it was stated that it was felt that the person that he knew in Ohio would be eligible for reciprocity, but that's not the way I read it. Under 4848 small b3, it says the applicant has either graduated from a veterinary college recognized by the board under section 4846 or possesses a certificate issued by the ECFEG or PAVE.
But this person has a license in the state of Ohio.
Correct, but that's stated earlier that they have.
Where is
that exactly again?
48 small b2. So they have to, under B, for purposes of reciprocity, the board shall waive the examination requirements of subdivision A and issue a license to an applicant to practice veterinary medicine if the applicant meets all the following. 1, the applicant holds a current valid license in good standing in another state, Canadian province or United States territory. Then further down in number 3, they've graduated from a veterinary college recognized by the board, which Berlin has not been, or possesses a certificate from ECFEG or PAVE. So my reading of this, she would not qualify for reciprocity.
Right, so members, if I can be so bold, it's B1, and then B1 says the applicant holds a current valid license in good standing in another state. Then good standing is defined as the applicant under the section, meaning 4848. A is not under investigation, B has no mental impairment, so I'm out. 2, at the time of original licensure, passed a national licensing examination. Okay. 3, graduated from a recognized veterinary college under 4846 or possesses the ECFVG or the PAVE. Is that, am I?
So needs to meet one of those 3, either graduated from a recognized school, ECFEG, or PAVE.
I think there's some credence to that.
I know we've discussed this before, but there's, at least from the AVMA's perspective, there's a difference between recognized and accredited. A recognized school is anyone that's on the list of 200 that the AVMA puts together based on addresses and calls to the jurisdiction of origin, asking questions like, is this school recognized in your country? Accredited are only those institutions where the COE has gone out and accredited them.
Is Berlin recognized?
It is recognized.
Okay, so I take that back. I'm fighting for your friend here, Alan. So, but I don't know if there are situations where they may be from an unrecognized school where they are practicing in another state that did not require PAVE or ECFEG. So.
In today's world, every state requires one or the other, to my knowledge.
Okay.
But in 1980, 81, 82, when we graduated, there were 8 or 10 of them that didn't require anything.
Well, then I'll shut up. I was just fighting for your friend, Alan. So, okay.
Mr. President.
So we have a motion and a second to recommend that the board not accept board certification as a tool. I'm trying to remember what the.
As satisfying some of the clinical requirements.
Okay, satisfying some of the clinical requirements. Other discussion? Committee, public? All right, so let's do the vote.
Dr. Klingborg.
Aye.
Dr. Druces.
Aye.
Dr. Grant.
Aye.
Dr. Pollard.
Aye.
David Johnson.
Aye.
Christy Pulowski.
Aye.
Jennifer Laredo. Aye. And Dr. Sullivan.
Aye.
The motion carries. We are now on agenda item number 14, public comment on items not on the agenda. Are there any public comments? Okay.
Ken, you're holding your breath. Does that mean something? Are you trying to force yourself to pass out so you don't make comments?
We actually said that we were going to have something brought up just to stress Kurt out,
Oh.
to go off the agenda.
So he's behaving himself.
It won't happen under public comment because anybody can say anything.
I know.
So that takes us to our existing priorities, I believe.
Actually, can we back up on dates real quick?
Yeah, let's,
Okay.
yeah, I don't have that. Is that easy?
Yeah.
Okay.
So for future dates, July 25th was, we changed the board meeting originally from the 3rd week of July to the last week of July because we were trying to, it's on the back page of your agenda. So you gotta look at your agenda. And it's item 15, yeah. So we did this because we were trying to avoid coinciding with AVMA, and now we're smack in the middle of AVMA. So I am going to ask this committee if we should not, and I'm going to be asking the board the same thing and probably give Ethan heartburn, but should we not back the meeting up to the third week of July because I don't know if this impacts anybody other than Dr. Drusi's, but it does impact people that need to be at AVMA, and we may lose some of our board members, some of our committee members, so I'm just throwing it out there.
Well, I have both in my calendar, so apparently.
Yes.
Actually, most of us are going to need to be there the 20th and 21st.
Okay.
So the 25th, 26th, and 27th actually
Is better?
is okay.
Okay.
For Bill and I and
Okay.
whoever's going for, so I
Okay.
can't speak, the actual convention is going on
Yeah.
the 24th and 25th, but we don't have to be there for that.
Okay, I just wanted to check before what about the folks that tend to join us at our board meetings? Is this going to be a conflict? Because I really want to have a meeting where we can have as much input as possible instead of everybody MIA.
We actually moved it from the third week to the fourth.
Yeah.
Okay.
Okay, okay.
And so it works for me. I'm in Spain.
Oh, hard one.
Okay, so we got the meeting dates, and October 17th still, okay?
In Fresno, yes.
That's fantastic.
Mhm.
Um,
I know, I thought you were going to be here in October.
Hey now.
Yeah,
So
see,
now
October
to our next agenda item, 15A, which is our advisory committee assignment priorities. We have the ongoing assignment, the case enforcement, the development of the minimum standards is part of the shelter work that SHAC and CVMA are doing right now. The extended duties conversation, I will be assigning a subcommittee to that. Developing regulations regarding compounding, Dr. Sullivan and I are subcommittee, and we're still working on that. We have dispensed with item 5, however, it has morphed into a request to talk about emergency aid that may be provided to animals. We have our work continues on item 6, the drug counseling information. It's not tabled, it continues. We will be suggesting that the board not pursue a separate standard for spay and neuter clinics, but use the fixed standard, fixed premises standard. We have also discussed the difficulty of having a committee of 1 when the 1 is Bill Grant for number 8. And then finally, we will be making a recommendation to the board regarding board certification as a proxy for clinical experience. So that's what I got. And so then I guess that brings us to adjournment. Is there a motion?
So moved.
All right. Meeting adjourned. Thank you.
It's been a long time.
No.